And then we'll also hear, the meeting is now being recorded. So we are aware. So general information about sarcoma, also some information about cancer and specifically sarcoma and COVID-19, which is actually data that we've put together, but in collaboration with a very large national consortium dedicated specifically to understanding what the risks are for patients with cancer, given the sort of uncertainty in the current environment. And then later, we'll also have some sessions specifically to talk about coping, and I'll thank them later, but I also want to explicitly thank the Northwest Sarcoma Foundation and the patients and caregivers who really make this possible. So now you can see our agenda. We'll have 2 dedicated panels for questions. So especially with this format, questions can be a little bit difficult while we're giving the presentation, just because you can't even necessarily see them on the screen until after the talk is done. So first at 11, so after the first 2 talks, and then again at the end of the whole meeting, we'll be answering any questions that you have, and we'll try keeping track of everything that comes in through the chat. And then at the end, so Dr. Kramer wasn't able to make it, but I'll be giving a talk just about research in sarcoma and where things might be going. So some things to know. So this is going to be recorded. And like I said, so please post your questions in the chat so we can keep track of them, and then make a point to answer them during those question and answer sessions. And then of course, during those question and answer sessions, you'll still have the opportunity to post questions as they come up during the conversation. If internet gets disconnected or you click the wrong button, you can rejoin using the same link that you originally joined with. So it's still going to be active. And what's the next slide? Okay. And that's it. So that's me. And I guess I will just get right into it. Just give me 1 second to share my screen. Okay. So at least to start us out, and I hope everyone can see and hear me. If you can't, then please post something on the chat and we can try and troubleshoot with you. But again, before we even get going, I want to acknowledge the Northwest Sarcoma Foundation. You'll hear from Joe McNeal, and many of you are familiar with, but they do really phenomenal work and are really the best advocates for sarcoma patients in the Pacific Northwest, at least in my opinion, short of you yourselves, the patients and caregivers. But they're a phenomenal resource and really cannot be thanked enough. And then also the Seattle Cancer Care Alliance, Fred Hutch, and University of Washington Med Center, who have also helped in organizing this, and especially Ritu Shriyan, who many of you have heard from, and really did sort of the key coordination to make this event happen. So first, what is sarcoma? So sarcomas are rare cancers, and they've actually been around for a while. So even if you just looking at paleontology, there's actually evidence, because it's bones, of cancers in the bone. And a couple of years ago, I saw an article that was specifically, showing this picture, and it's one of the oldest cancers that had ever been identified, and it's actually a tumor in a bone from one of the ancestors of, I think it was a turtle or something like that. And it's just fascinating. So this is a disease that's been around. It's been challenging, animals and creatures long before there were even humans walking around. And we're still trying to understand it and find good ways to treat it. And sarcoma literally means an abnormal flesh growth. So the origin of the word is sort of the Greek sarco, which means flesh, and then oma, which is the Latin suffix for really any abnormal growth. So you've heard things like carcinoma, which is what most cancer types would be classified as, and other omas. And we just tack that on to the end. So sarcoma is literally just a growth of flesh. And they're rare, but if you add up all of the diagnoses of rare cancers across all cancers, rare cancers ultimately actually become not so uncommon. So about a quarter of all cancer diagnoses are what we would call rare cancers. And sarcomas in general are included in that categorization of rare cancers. There's about 20,000 people who are diagnosed with sarcomas of all sorts in the US every year. And that includes people with bone sarcomas, soft tissue sarcomas, and also gastrointestinal stromal tumors. And the sarcomas can arise in people of all ages. About 1% of cancers in adults is sarcomas. And so we say that they're more common in kids, but the reality is that if a child were to get cancer, it's just more likely to be sarcoma. They're still very rare, but about 15% of all pediatric cancers are sarcomas. And they can start anywhere in the body. And part of the reason for that is because going all the way back to when we were embryos actually have 3 layers of cells. And those layers have very determined fates and will develop into different parts of our body. So most cancers will actually form from what way back in the embryo was the ectoderm layer. So things like breast cancer, colon cancer, lung cancer. And what differentiates them from sarcomas is sarcomas are cancers that have derived from things that originally were in the mesoderm, or that middle layer of cells. And things that come from that layer of cells are things like bone, cartilage, various connective tissues, fat, blood vessels. And when any of those tissues develop a cancer, it's usually a type of sarcoma. And usually we don't actually even know what causes the sarcomas, but we have some sense for at least specific types of sarcomas. So probably one of the most well-known ones is gastrointestinal stromal tumors, where the vast majority of those tumors have a mutation in genes that are called either KIT or PDGFR, and we actually have drugs to target that now. A number of sarcomas are driven by chromosomal translocations, so meaning the chromosomes can actually break apart and then come back together again. And sometimes if they come back together again in certain ways, then that can lead to uncontrolled cell growth. And there are certain types of sarcomas that have very well characterized chromosome changes. And those include Ewing sarcoma, a number of different pediatric, especially rhabdomyosarcomas, EHEs, epithelioid hemangioendothelioma, which is a very rare cancer of the blood vessels, solitary fibrous tumor, which is another pretty rare type of sarcoma. But all of those have very well-defined chromosome changes. And there are some genetic syndromes that can predispose people to getting sarcomas. Probably one of the more common ones is a syndrome called Li-Fraumeni syndrome, which is a genetic change in a gene called TP53. And it can cause actually many different types of cancers, but sarcomas of various sorts is one of them. And as many of you know, so prior history of radiation for any cause, but really other cancers generally, can also increase the risk of someone to develop a sarcoma. That risk is actually very, very low. So I would say less than 1% of people who get radiation will have a secondary sarcoma because of it. But it is a risk that can happen. And what do these things look like? So this is just one example. They look very different depending on where the tumor is, what the type of tumor is. And even just what the imaging modality that we're using is. But this is an example of a patient who had a liposarcoma of his abdomen. And I'm not sure if you can see my mouse, but in the middle on that picture on the left, that big ball-like thing is actually the sarcoma. And it's a picture as if we're looking straight on at the patient. And then on the picture on the right is like we're looking at the side. So oftentimes you'll read news stories about someone having a 20, 30-pound tumor removed from usually their abdomen or their belly. And more often than not, that tends to be a sarcoma just because of the growth patterns and where these things come up. It's not always the case, of course, but that is something that we'll not uncommonly see. And many folks will have imaging, so really everyone will have some sort of imaging, and there's different types of scans and images that we can get, and we'll use different ones because they give us different bits of information. And for some folks, an MRI is absolutely needed. Sometimes it's not. It wouldn't really add much to what we're doing, and it wouldn't change the treatment plan. So MRIs, of course, are one type of scan that we'll often get, and they're very important, I'd say, for sarcomas that start in the arms and legs, so in the extremities, in the head and neck, especially in the soft tissue, and then in the chest wall, or really abdominal wall, or any part of the body that primarily consists of muscle and fat. And the reason for that is because the MRIs can give us much better definition and better clarity for what is cancer, what is just normal muscle and fat, what might be just inflammation. And an MRI gives us really the best picture, I would say, for determining those things, especially for looking at size. And they're particularly critical if we're trying to, for example, preserve someone's blood vessels with a surgery, and the surgeons will really want to know how close does this sarcoma get to those important structures, and can we dissect it off and preserve the nerve and the blood vessels, or in order to remove the tumor, is the tumor too close or invading even into those important structures where the surgery might actually have to be different. A CT or a CAT scan is a different type of test that will get most patients with sarcoma are recommended at least to get a CAT scan of the chest. The reason for that is because when most types of sarcomas do spread, they tend to go to the lungs. We don't have a great understanding for why that is. But that is just something that's been recognized for a long time. And we'll get CAT scans because the CAT scan gives us the best picture of the lungs specifically. And it also gives us a really great picture to differentiate the anatomy inside the abdomen and pelvis. So a CAT scan, particularly in things involving the gastrointestinal tract, so things like the stomach, the intestines, CAT scan will usually be what our surgeons especially would prefer, because MRIs take a long time. Those organs are actually moving, and the picture that we get with a CAT scan tends to be the best one in that particular part of the body. Many times we'll also get a PET CT, so we don't often get it, but there are certain circumstances where it's useful. What differentiates a PET from an MRI or a CAT scan is that the contrast, or the thing that is injected to actually help us see what's the cancer versus what's not, is actually a radioactive sugar. And any actively growing or just metabolically active cell will take up that radioactive sugar just like it would take up normal sugar to get energy. And in the sort of detection machine, we can actually see that. And if a tumor is particularly active, then it'll actually light up like a light bulb on the scan. And that can give us an extra bit of information that we wouldn't get with an MRI or a CAT scan. Another nice thing about a PET CT is that we would usually order a whole body scan, and that can be particularly helpful if it looks like there's disease in multiple parts of the bodies, especially in the bone, Or just as an example, so a lot of times, for example, angiosarcomas will come up on the scalp or in someone's extremity, and we want to see both what or how much tissue is involved, and then also has it spread. And a PET CT is actually a pretty good way to help us differentiate that. And then many folks, especially with already known bone disease, will get a bone scan, and that's really great at identifying metastases in the bone. But that's more or less the only bit of information that we get out of the bone scan. So oftentimes we'll do a PET CT instead of a bone scan. But in some cases, a bone scan is actually usually what we would want. Now, there are many, many different types of sarcomas, so over 100 kinds, and depending on who you ask, you'll get a different number, but any one of those numbers will be a lot. So that's what we all agree on. There are many different types of sarcomas, and the differences depend on where did the cancer start. And even if it started in the same place, sometimes they can have different appearances under the microscope. And that can be because of different genetic changes or just other reasons that we don't fully understand. And the pathologists have very complicated naming systems and will generally try and apply a name to someone's sarcoma. But sometimes, even with all sorts of testing, they still can't pin down a specific name to an individual's tumor. And sometimes we'll even get a diagnosis that is just a high-grade spindle cell sarcoma. And in spite of some of the additional testing, they just aren't able to place a name to it. And the list that you're seeing here, this is just a list of soft tissue sarcomas. So there's an equally long list of bone sarcomas, and I'm not going to show that because it's just a very long list. Just to highlight the importance of the pathologist, so with all of those different possibilities and the nuances in diagnosing sarcomas, it's actually very important that sarcoma, at least in my opinion, and this is generally accepted within the sarcoma community, that any patient who has a diagnosis of a sarcoma should at least have their pathology reviewed by a sarcoma pathologist. And there are actually studies to support that, where a number of years ago, a few hundred sarcomas were reviewed by academic pathologists. And in general, the experienced sarcoma pathologists agreed with the diagnoses that they were coming to. But when those same sarcomas were looked at by less experienced pathologists, sort of uncomfortably high number of the cases were misclassified either as a sarcoma or as something that was not sarcoma and it should have been sarcoma. And it's very important to know what type of, not only cancer, but even if we know you have a sarcoma, what type of sarcoma one has, because that does impact treatment. And that's actually becoming more and more true as we learn more about the biology of the different types of sarcomas. We have more and more drugs, which I'll mention in a few minutes, that are specifically approved for certain subtypes because we know more about the biology of what makes them grow. So the pathologists, even though especially from the patient's perspective, they're this sort of mysterious person who's writing a report and nobody ever meets them. They're actually very important and critical members of the medical team because they, arguably even more than anyone, will decide what the treatment plan should be just by virtue of providing a name to a specific sarcoma. And just to give you an example of how difficult it actually is to be a pathologist, so this is a figure that was from an older paper, but the paper was talking about different types of gastrointestinal stromal tumor. And these are images of various gastrointestinal stromal tumors as seen under the microscope, the way that the pathologists stain it. And every single one of these pictures actually is a GIST. So it is a gastrointestinal stromal tumor. And I, as a medical oncologist, could not tell you that. But we really need the pathologists to differentiate panel A from panel B from a panel that's not even here, which is a totally different type of sarcoma. So moving on to sort of the next phase of this first talk. So how do we treat sarcomas? So as many of you have learned and seen, there are many different types of doctors who you'll be meeting with or who you have met with. And we all are super specialized. So we all have certain areas of expertise. And really, all of us provide important information and important expertise to develop an overall plan of care. And that includes surgeons, the radiation oncologists, and sort of a lump in the radiologists, who are actually entirely different from the radiation oncologists there. But they're the folks who actually look at the scans and interpret them, especially the difficult scans. Medical oncologists, so you'll hear from Dr. Lagers in a bit, who's one of my colleagues, but we specialize in systemic medicine, so that can be chemotherapy or more targeted drugs. But in many cases, you'll meet many of us because most patients will require a combination of these therapies to really get the best care. And sort of along those lines, so we have sort of national guidelines for how every different type of cancer should be managed. And there are a few different guidelines specifically for different types of sarcomas. And in the sarcoma guidelines, it actually specifically says that any patient with sarcoma should be evaluated at a sarcoma center. Doesn't mean you need to get all of your care at a sarcoma center, and it doesn't even mean it needs to be in Seattle. But in order to get the sort of super specialized care, because sarcomas are rare and because there are so many nuances to how they're treated, it is actually recommended in the official national cancer guidelines that patients get opinions or at least an evaluation, even if that just means having the pathology reviewed at a sarcoma center. And we meet. So in Seattle, we meet actually twice a week to review imaging and pathology, and the surgeons and radiation oncologists and pathologists and medical oncologists are all there. Now it's on Zoom. We used to be physically in the same room. And we look at the scans, we look at the pathology, and we actually talk about the patient-specific factors. So we'll take into account if someone lives 4 hours away, what might be the best approach to try and develop a tailored treatment plan specifically for that individual patient. So taking into account what does the literature say, what's the treatment that's absolutely needed, and what can be done even closer to home if possible. And there are two concepts that I want to introduce. So there's one that's called local control, and that is specifically trying to prevent a cancer, so in this case, sarcoma, from coming back where it is. And the modalities that go into that are generally surgery, radiation, and then sometimes in certain cases, interventional radiology. And I'll talk a little bit more about some methods that they can use, like ablations and things like that, to try and either kill or remove a tumor so for example, if it's in your arm, so in someone's arm, and then hopefully make it so it never comes back, especially in the arm. And then sort of on top of that, there's systemic medicines. So things like chemotherapy, targeted medicines, will now lump immunotherapy into that category, where in general, the main goal of systemic medicines is to try and prevent the cancer from coming back, or to treat the cancer that exists in other parts of the body from where it started. And we think of disease that's localized in one way, and then disease that has spread or is in multiple parts of the body in a very different way. And this is our sarcoma team, at least in Seattle. So we have, I would say, a phenomenal team. And these are the folks who are actually participating in those multidisciplinary tumor boards, where we have now 3 medical oncologists, 2 orthopedic oncologists. Dr. Mogul, who's in the middle, is the sort of main sarcoma surgical oncologist now. But we have other surgical oncologists who also have expertise in doing the complicated surgeries that is required often for patients with sarcoma. We have 2 sarcoma-focused radiation oncologists, and then the folks on the bottom right are our excellent pathologists, who are the ones who you really never see, but like I said, are really critical members of the treatment team. And actually didn't have pictures of the radiologists, but they're also critical. So they help us interpret the MRIs and the PET CTs and the CAT scans. And just as you might imagine, those are actually very complicated pictures and sets of scans. And sometimes we can interpret them ourselves, but in many cases, and especially if there's a question of if an important structure is involved that may or may not need to affect the surgical plan, or sometimes even if someone's getting surveillance scans and it's not clear because a patient's already had a big surgery, so the scan's never going to be quote normal, but we're trying to figure out, are we actually concerned that there's a recurrence here? And the radiologists are really critical in helping us differentiate what is just normal scar tissue versus what is actually concerning for cancer and things like that. So now just to dive a little bit more into the different treatment modalities. So first, surgery. So that will depend on what subtype is it. So that goes into the surgical decision making. Where is it? So is it on someone's arm or leg, or is it in their abdomen? The retroperitoneum is more in the back, kind of where the kidneys are. Is it in the chest? And depending on where it is will actually impact which surgeon you see, because surgeons are very specialized in certain anatomic body areas. Are there 1 or more tumors? And then also, what else would have to come out? So if there's for example, a tumor in someone's back or retroperitoneum, sometimes a kidney would actually have to come out, which is not a small deal. We would generally recommend surgery for really any localized sarcoma. If there's a sarcoma in the abdomen or retroperitoneum, then a surgical oncologist would be the primary person. So that would be Dr. Mogul, Dr. Kim, Dr. Sham, Dr. Pilarisetti, at least in our center. And as part of the surgical planning, they have to identify, and sometimes you don't even have this answer until you actually attempt the surgery, but what's the blood supply to the tumor? Are any important blood vessels or other vital organs involved with this cancer that might have to either be removed or in some way an attempt made to save those organs, but still remove the sarcoma? And then sometimes if they are involved, then a surgery might not actually be the best option. And then sometimes we'll actually combine other modalities even during a surgery. So there's something called HIPEC, which is a specific type of chemotherapy that Dr. Mogul actually specializes in intraoperatively. They can deliver that inside the abdomen. And we don't do that very often, but there are certain cases where it might actually be useful. And then also sometimes if we know especially that it's going to be incredibly difficult to completely remove cancer, and we're expecting that there might be some left over specifically to try and preserve an important structure and an important organ, then the radiation oncologist will sometimes even coordinate with the surgeons to do radiation in the middle of the surgery. And if there's a cancer on the extremities, so historically, many, many decades ago, people would get amputations for sarcomas. But now we know, and there have been very well-designed studies to show this, that limb-sparing surgery is actually now considered the standard of care whenever it's possible. It's not always possible. And even in the setting of an amputation, there have been so many advances with prosthetics now that people can actually be quite functional, even if you have an amputation. And I mean, of course, there's, knowing that you've had to have that really big change in terms of getting an amputation or getting a big surgery. But by working with our physical therapists and the prosthetics folks, one can actually have a good quality of life, even in spite of having these major changes as needed for the treatment of the sarcoma. And then radiation is a separate modality, and it can be given either before or after a surgery. And we'll use it in two different settings. So one is curative. So if someone has a localized sarcoma and we want to try and prevent it from coming back, especially in that specific spot, then the radiation oncologists will give what we would consider a curative dose, which is a pretty high dose of radiation that can be given actually before or after the surgery. In terms of outcomes, it's in terms of survival, at least outcomes, it's about the same, or it is the same. The difference is the side effects and some of the risks specifically around the surgery. So things like wound healing and wound infection risks change depending on whether or not you get radiation before or after. And there are different types of radiation. So electrons is the standard way, and that's what most people ultimately probably get. But then there's also more specific things like protons and neutrons, which the radiation oncologists can tell you all about, but that's a bit beyond my understanding, is more on a high school physics level. And then I mentioned interventional radiology before. So the interventional radiologist can actually do some pretty impressive and high-tech things where, especially if a surgery is not possible or a surgery would be incredibly morbid. So, if a surgery to remove a small nodule in the liver, for example, would require a massive resection of part of one's liver, the interventional radiologists can actually offer some different things where they can do a cryoablation, where they literally stick probes into the tumor and then those probes freeze everything around it. And by freezing it, you actually can kill the tumor. And then similarly, there are other ways to do it as well, where there are different types of probes, and they can use radio frequency, where it's almost like you're heating the tumor. So instead of freezing it, heating it to kill everything that's in a certain area around that probe. And this can be particularly useful in certain circumstances when a surgery is not really the ideal option, but it also depends on the location of the tumor, because there are just certain technical limitations to interventional radiology. Is there anything we can do to prevent cancers from coming back? So imatinib is one thing that we now know, especially for patients with GIST that's particularly high risk, can be used. Sometimes we'll use chemotherapy, and we already talked about radiation, especially for localized tumors. But in general, outside of imatinib and radiation, it's kind of controversial if chemotherapy works to prevent cancers from coming back. We take a very personalized approach, and there are some particularly high risk patients and particular tumor subtypes where we absolutely will have to do it, like Ewing sarcoma, osteosarcoma, certain types of rhabdomyosarcoma. And then a question that we get very frequently in the clinic is, are there any specific diets or supplements that can prevent a recurrence? And the real answer is no. However, it's always good to have a healthy lifestyle and exercise, and make sure you're getting enough nutrition and vitamins and the things that really anyone, whether you have cancer or not, should be doing to stay healthy and hopefully feel good. And then just the last thing, so I think I have 2 more slides and a little bit over time, but the last thing that I wanted to talk about is chemotherapy and systemic medicines. So the goal with systemic medicines is to treat any cancer cells, whether you can see it or not, that might be really hiding out somewhere in your body. There are many different types of chemotherapies, and I'm not listing them all, but some examples that we use for sarcomas are things like doxorubicin, which is one of the oldest chemotherapies that we have in use. It's been around for decades. That's the red devil that everyone talks about, because most people with sarcomas ultimately will get it, especially if it's spread, and it comes with side effects, but it also, in spite of many, many clinical trials that I'm not going to go into, still happens to be one of the best drugs that we have against sarcomas. Gemcitabine is another common medicine, trabectedin. There are now a few targeted medicines. So about 20 years or so ago, imatinib came into play, where that's a targeted medicine for that specific mutation that makes GIST tumors grow. So it's actually very effective at controlling and even shrinking GIST tumors. I'll talk more about immunotherapy in the research talk, but that's something that is very exciting for oncologists and really just the cancer field in general, because it really has revolutionized how cancer is treated. And then, of course, clinical trials, where we're still learning, and clinical trials are a critical component of that. Just as a few examples of some things that have been approved even just over the past 10 or so years. So trabectedin was approved for leiomyosarcoma and liposarcoma. I forget exactly when, but within the past 10 years. Eribulin is now approved specifically for liposarcoma. Pazopanib is a targeted sort of oral chemo that still comes with a fair bit of side effects, but that's approved for most soft tissue sarcomas and not liposarcoma. Tazemetostat was approved very recently, actually, and that is specifically approved for epithelioid sarcomas, which is a very specific thing. And that's a really great example of how understanding the biology of the cancers has led to new treatments for the more specific subtypes that otherwise were just lumped in and treated just like any other soft tissue sarcoma. And then same thing with PVNS, or so pigmented villonodular synovitis, or tenosynovial giant cell tumor. So this is a type of tumor that has a lot of really long names. But by better understanding the biology of that specific tumor, there's now a drug that is actually quite effective at shrinking them and controlling people's pain, especially, which is something that this tumor can cause. And pexidartinib is a drug now that we'll use. And hopefully many more will come in the near future. So we have clinical trials. There are clinical trials across the country and the world where we're using the biology that we're learning, and especially identifying specific genetic changes and other things that we can see in specific subtypes, and developing trials to try and more smartly target the cancers by developing drugs that, at least we think, are more effective than the chemotherapies that we have, and then ideally even potentially having less side effects. So to conclude, so sarcomas are rare cancers, and they require very specialized multidisciplinary care. And in spite of many advances, we still have a lot of work to do. So thank you all for listening. I apologize for going a few minutes over. And Dr. Loggers, I believe now, will give a talk about COVID-19 and, how does that impact cancer care? And specifically, what is the relevance of it for patients with sarcoma?
Well, good morning, everyone. Mike, can you give me the thumbs up if you can see everything? Okay, wonderful. Thank you. Just want to make sure. I am Elizabeth Loggers, as Dr. Wagner said. I'm one of the medical oncologists at the Seattle Cancer Care Alliance. I'm also the medical director for supportive and palliative care there at SCCA, and that's a form of specialized medicine that focuses on quality of life, symptom management, and coping in people with serious illness like sarcoma and their loved ones. So I don't have any disclosures that are specific to this talk. Here's the outline of what I'm going to be discussing today. As a history major in college before I became a physician, I love to talk a little bit about the history and the context. I hope that isn't going to be boring to all of you. Whenever we do these talks, we always try to, hit that perfect balance of not taking anyone's knowledge for granted, but also trying to present something new and interesting to you all. So I hope you'll find that the case today. But I am going to do some background just to make sure we're all understanding some of the same things. And then we're going to jump into specifically, as Dr. Wagner said, how cancer and COVID-19 interact. And then where do we go from here? This has just been a whirlwind, hasn't it? This pandemic, and what do we make of it, and how do our lives change going forward? I am going to go pretty quickly because I'm going to try to make up a little time so that we have lots of time for questions. So this is, as a history major, one of the quotes that I just love, right? If we don't know our history, we're doomed to repeat it. But I think, as you'll see on my next few slides, this quote might also be important to keep in mind. This is from a famous James Bond movie, Goldfinger. Some of you may or may not be old enough to know these movies, but I am, where he basically said the third time is enemy action. And I think that's really what we've experienced with COVID-19. So let me just get started with the coronaviruses. COVID-19 is actually part of a large family of viruses called the human coronaviruses. If you remember your high school biology, with the kingdom, phylum, order, all of that stuff, there are 4 genus or genera of viruses: alpha, beta, gamma, and delta. And in general, it's the alphas and the betas that are the ones that infect humans. And these are not structural, the names. These are just simply how we keep track of which virus is which. These are what are called medium-sized positive-stranded RNA viruses. And they're named, as you've, I'm sure, heard, for this, for these spikes. This is the corona. This is the thing that makes these special, in addition to the fact that they're part of what's called the Nidoviralis order of viruses. And that's because as they replicate in our human cells, they form these interesting nests because of the way that the enzymes that help them reproduce their viral genome actually touch and then break off and touch and break off. So you have to imagine kind of almost like a bird's nest inside our cells. And so this is happening in the cytoplasm, which is that space between the outer part of the cell and the nucleus, where our genetic material is. So this coronavirus comes in, it latches onto our cell, it shoots its viral genome into our cytoplasm and then starts replicating there. And again, what's interesting about it is it's using our own cells' mechanisms in order to do this. And these are some of the largest viral genomes that we know of, actually. And they only encode for about 4 to 5 major structural proteins. I think this is fascinating, right? It's like this, it's this little nugget that can do so much harm in our bodies with just 4 to 5 structural proteins going on to create all that havoc. These are viruses that we've actually known about for many decades. And in fact, they were known to represent about 1/3 of the common cold prior to 2019, before we came to know of COVID-19. So I love this little cartoon from The Economist. I know, a weird source, but you take a good cartoon when you find it. So when you look at this, these are those 4 human coronaviruses that we knew about before 2019. These first 2 are alphas, these last 2 are betas. And these, like I said, they cause the common cold. Nobody really got excited about this until we start seeing what are called our first spillover events. So spillover in this context means that these are zoonotic viruses. These are viruses that start in animals, but then jump to humans. And when they jump, that's called a spillover event. So there's been at least 3 major spillover events in human coronaviruses. And you may remember this, again, like a history major, I just want you to think about, we knew about this class of viruses for a long time, and we knew that there were serious illness that could come from it. The first of that is the SARS-CoV virus that I'm showing here. And it shows this intermediary host, which is a civet, which is like a cat, and then MERS, or Middle Eastern Respiratory Syndrome, which is infected dromedary camels. And then here on this end is COVID-19, right? This is the SARS-CoV-2 virus that causes the current pandemic that we're experiencing. And what's interesting about this is the COVID-19 virus is about 96% similar to a known bat virus, right? So we believe that it's, that just like these other viruses, it started in a bat. It probably makes a jump into some other intermediary host, which we're not sure what that is. Some people thought maybe it was a pangolin, which is this anteater mammal thing, which is You got to look it up. You got to go to Google, search pangolin. It's incredibly fascinating. But now more recent research is actually thinking that possibly where SARS came from and why it's called novel is that it may have actually been a subject to a recombination event where some animal was infected by 2 coronaviruses and they swapped material, and out comes COVID-19, and then it finds its way into humans. And again, this is still a virus that is about 80% similar to the SARS virus that we already knew existed. So SARS, according to the World Health Organization, was the first severe and readily transmissible new disease to emerge in the 21st century. Wow, what a title, right? And so here it is. The bat that it comes from, Google this one too, is a horseshoe bat. Very interesting. And it caused about 8,000 cases. Now I'm going to show you what that is in comparison to COVID, right? Nothing. It's a drop in the bucket, and about 1,000 deaths in 2003. And this was actually contained and really isn't seen anymore. Had an 11% case fatality rate, and you can see there the rates of admission to ICU and ventilatory support. So serious. And in fact, when you look at what it looks like in terms of what the infection looks like, boy, this looks familiar, right? Doesn't this look just like what we've been dealing with COVID-19? Nothing really surprising there. And then comes MERS, Middle Eastern Respiratory Syndrome. And this actually begins in Saudi Arabia in September of 2012. And there were many fewer cases, so about 2,500 cases and about, again, 1,000 deaths. This virus is still active. We know it still is within the camels, and it's still being spread back and forth to the humans who care for these animals. And again, the major point that I'm trying to make is that different from SARS, this has been found in 27 countries and continues to be present. So we, again, we've known about this, and then this, like the SARS information, really is reminiscent of what we know about COVID-19 now. The difference being is that because of the place in the world where this was discovered, a lot less research was done in 2012 regarding this, and a lot fewer tests. So we don't really know if that 35% fatality rate is because of a lack of testing, meaning that we don't know who's in the denominator. We don't know all the people who got infected. So when we look at who died, it seems larger than it might actually be. And here is just an example of what the World Health Organization created in terms of educational material for people to help warn them about what to do if they were in a MERS infected area. And again, very similar. The only difference here is that at that time, there weren't a lot of masks. You know, there wasn't a lot of personal protective equipment. And so they were only recommending healthcare workers to use it. But now we know, right, that all of these viruses are being transmitted in very similar ways, coughing and fomites, things that are infected that we touch, and then we touch ourselves and infect ourselves. So again, just the point being, this is stuff that we knew, but we didn't really learn from when it first happened. And then comes COVID-19, right? So now 161 nearly million confirmed cases and more than 700,000 cases each day still. This is updated information as of May 14th from the World Health Organization. So greater than 3 million deaths and amazingly about 1.3 billion vaccine doses already given. So there, if you think about it, right, there were 7.8 billion people when the pandemic starts. And the US makes up about 4% of the global population with 330 million people. So about, if you think about it, about 2% of the world's population has had COVID, but this is seen. And about 33 million US cases. So about 20% of all global cases happened in the United States, and about 570,000 deaths. So about 17% of the global deaths happened in America. Really astonishing, right? What we've all been through in these last year. So now let's dive into COVID-19 and cancer. This is also just background. 44 million global cancer survivors out there as of 2018, and about 18 million new cases per year globally. About half of those individuals will die of their cancer. And then, you know, there are the specific US statistics. But if you think about it, basically there were about 9 times as many COVID cases as new cancer cases globally in the past just since the pandemic began. Amazing, right? That there are that many cases this quickly. And I just also want to point out that there were in the United States 606 approximately 1,000 deaths from cancer in 2020. But I just told you that there were about 578,000 deaths from COVID. So COVID-19 incredibly rapidly becomes one of the most common causes of death in the United States, approaching, the second leading cause of death, which is actually cancer in any given year. So I'm not going to go through all the studies. There's a list at the end of my talk of references of studies that have looked at cancer and COVID-19, but there are many, there are more and more studies that are being published all the time that are looking at what are the risks when cancer patients acquire COVID-19. And the bottom line is that, the quality of the studies is variable. A lot of these studies tend to be cohort studies where we basically look at people who had cancer and COVID and compare them to people who don't have cancer but who got COVID and what happens to them thereafter, after that infection. But it's important just to note that most studies are, do find that there's an increased risk of death in people with cancer who get COVID compared to people who don't have cancer and get COVID. And that mortality rate is actually about 30% for people with cancer who are hospitalized compared to 21% for people who do not have cancer who are hospitalized for COVID-19. And in fact, some studies that look at these cohort studies where they're looking at, what is the increased rate? How much more likely is it that you are going to have, admission to ICU or ventilatory support or that kind of thing for your COVID-19 exposure if you have cancer? It's about, most studies, it's about 2 to 3-fold higher risk of one of those serious outcomes, including death, if you're a cancer patient who acquires COVID. So, as Dr. Wagner hinted, we're of course incredibly interested in the specific experience of sarcoma patients who wind up getting COVID. And there's only so many ways to study this problem and get a large sample size because sarcoma is such a rare condition. And so we, Dr. Wagner is the local PI for the PI for this study, and I'm part of the study as well. This is part of the COVID-19 and Cancer Consortium, or for short, CCC-19. It's an international registry, actually. So we are identifying people, adults, 18 years or older, who have a sarcoma, any cancer diagnosis, actually, who then go on to also have a diagnosis of COVID-19, but in particular, we were looking at the 228 patients in this international registry with a sarcoma diagnosis. And we found these individuals in 56 institutions during the time from March 17th, 2020 to April 23rd, 2021. And here are the demographics. This is what this population looks like. Basically about 60 years old, pretty evenly split between males and females. About half of them had had cancer treatment in the last 3 months, and 75% had active cancer, which means about 25% either were currently without evidence of cancer or were survivors, so had their cancer before and were in that post-treatment period. About 20% had lung metastases, and we followed them for about a median of 42 days since their infection. When you look at this ECOG performance status, in case you're not familiar with what that means, that basically means how is that person doing? When the ECOG performance status is what's called 0, that's basically somebody who has no symptoms at all. When it's 1, it's basically an individual who might have some symptoms, but is up and about doing their everyday life. And then when it's 2, 3, or 4, it's basically somebody who has pretty significant symptoms and may be spending a good part of their day sitting or laying down. So this is a busy, there's a lot going on here, but basically what it's showing you is the different kinds of sarcoma that these 228 patients had. So here are the bone sarcomas, the soft tissue sarcomas, a number of which we've talked about today, and then the gastrointestinal stromal tumors. So 35 of those individuals, about 15% of the sample had GIST. And this is just showing how many of these individuals were over 60 years of age or who had recent systemic therapy. So you can see, as you might expect, that some of the more serious subtypes were more likely to have had cancer-directed therapy in the last 3 months. And then this is what's called the composite outcome. So what we were interested in is how many people are either hospitalized or die after they get their diagnosis of COVID-19. And this is what that's showing, is basically the percentage, the number and the percentage of people in each of these categories who goes on to be hospitalized or dies of their following their COVID-19 infection. And in this study, basically 33% of patients required oxygen, 9% were admitted to the ICU out of the 45% of people who were hospitalized, and 8% go on to die within 30 days of their COVID-19 diagnosis. What's interesting about this is that the rate of hospitalization and death was pretty similar for people whether they got chemotherapy here or targeted therapies. So there wasn't this big difference, which you might have wondered about, right? Maybe it's the neutropenia, the low white count that's causing people to be more susceptible to the COVID-19 when they are infected with it. And here are the factors that are associated with hospitalization and death. So what makes it more likely that you're going to be hospitalized or die if you have sarcoma and have COVID-19? And that's age greater than or equal to 60 years. And you can see by this odds ratio about how many times greater, right? So it's almost 2 times more likely to be hospitalized or die if you're over 60, or like I said, if your functional status, your performance status is worse. This was a big, it's a big window there, but of risk, but that's partially due to the small sample size, I'm sure. And then there are any systemic therapy, again, about 2-fold more likely, and then 2-fold more likely if you had lung metastases. So if you were to have cancer in your lungs, you are more likely to be hospitalized or die. So that just kind of gives you a brief overview of what we found when we looked at this sarcoma-specific experience of individuals who had who acquired COVID-19. Now, I just want to briefly touch on treatments that may work for sarcoma. So if you for COVID-19. So if you are sick, symptomatic from that infection, what are the things that doctors are using right now to try to help that person get through that infection? And in general, these are the things that have had at least one major trial. And by major trial, I mean there had to be at least approaching 100 people in that study, and it had to be randomized, and it had to be published in a high quality journal with methods and outcomes that seemed appropriate. So here we see dexamethasone, which is a steroid, remdesivir, which is also called Veklury, which is an antiviral medication that helps prevent the virus from replicating in our cells and causing more and more of the virus to be made in our bodies and make us sick. And then I'm not even going to say it, I'm just going to let you read it. The thing that starts with T, tocilizumab, which is also called Actemra. And this is a monoclonal antibody that basically helps our bodies identify the virus and fight it. And so these 3 treatments are the treatments that have right now the most evidence for them. There are lots of trials going on right now to try to find treatments that do work. And I'm sure you're seeing a lot about this as you're looking at the newspaper and listening to podcasts and things like that. These are the things that probably don't work. And we've heard a lot about them. Again, I'm going to go just very briefly because I want to try to finish on time. But these are the things that, at least in the larger studies that have been done, really have not seemed to show differences in outcomes between the people who got them and the people who were randomized to get usually a placebo, basically, a not active agent, a fake sugar pill or that kind of thing. And now I'm going to turn my attention to vaccinations. Boy, has this been a big week for conversations about COVID-19 vaccinations. You're probably tired of it, but I just want to point out that earlier in the week, on the 12th, the CDC said we can now start vaccinating our kids from 12 to 15 years old. And they based this decision on the FDA's expansion of the existing emergency authorization that had come out on the 10th. So basically the start of the week, Monday, we hear that from the FDA. The CDC on Wednesday says, okay, let's start getting the kids vaccinated. And then the next day they come out and say, for those people who are fully vaccinated, they can stop wearing masks in most public settings. And the reason they say this is because within the month of May, there's been a couple of really large studies, one from Israel, one from the United States, where they looked at, again, a cohort study where they looked at people who had gotten the COVID vaccine and those individuals who had not, and how likely they were to get COVID after the individuals who'd been fully vaccinated completed that vaccination period. So what we mean by that is, you get your vaccine. If it's the Pfizer or the Moderna, there's 2 doses. And then about 2 weeks later, you're considered fully vaccinated. So they looked from that period on to see how many people went on to contract COVID. And they were looking at healthcare workers. And they did this because healthcare workers are really motivated, one, to get the vaccine and participate in trials. But also this is what's called a real world experiment. This isn't a clinical trial. These people are out in the world being exposed to COVID, and they're at high risk. And so it's easier to pick this up if you're looking in this real world population. And basically in both of them, I'm only quoting one of them, the one that the CDC quoted on May 14th, when they basically said that people who had gotten fully vaccinated were about 94% less likely to get COVID than people, who were not fully vaccinated. So this is the basis, these studies and others that had come out before it, of reversing their stance on mask wearing, because they are now more convinced that if you are fully vaccinated, both shots, if you're getting either the Moderna or the Pfizer, you're going to be well protected. So now turning to vaccination in our cancer population. A lot of the advice around how to be vaccinated in cancer patients is basically based on the vaccination guidelines that already existed for cancer patients. So, we've already been vaccinating people for flu, for varicella, for pneumonia, all sorts of things. And there were standing recommendations, and a lot of those have largely been adapted to fit this current situation. And basically what they're saying is that we don't fully know what the safety and efficacy is in people who might be immunocompromised, either because of their disease or because of their treatment. But these are not live viral vaccines. You're not going to get the disease from the vaccine itself. And as long as you don't have a history of some kind of contraindication like anaphylaxis to some component of it, you should get vaccinated if you have cancer. And the optimal timing isn't completely clear, but if you are currently sick with COVID-19, you should wait until you recover to be vaccinated. Then ideally you would get it, and this is coming from ASCO, the American Society of Clinical Oncology, and the World Health Organization, as well as other articles. But you should basically get that vaccination about 2 weeks before you start immunosuppressive therapies if you can. But if you cannot, you should get it anyway, is what they're basically saying. And that you should administer this without regard to whether you're using steroids, either for your treatment or for aches and pains, joint things, that kind of thing, or whether you're on a clinical trial. And the only exception is people who are getting transplant or adoptive cell therapies where they might not have enough of the immune system at that moment to actually build a response. If you're going to delay the vaccine, you really need to weigh that in relation to the or delay treatment in order to get the vaccine. You've got to weigh that with your underlying condition. And they don't recommend antibody testing to assess whether or not you actually formed a response. And then you want to continue to protect yourself against COVID-19. So while the rest of the world might be taking off their masks, if you don't feel comfortable, if you're not fully vaccinated, if you're not certain about your immunity status, then probably, best to be safe rather than sorry. This is one of the few studies that looks at vaccination in cancer patients receiving checkpoint inhibitors. And basically what they did is this is a study from Israel using the Pfizer vaccine, again, a cohort study where they looked at people who had not received checkpoint inhibitors for their cancer and people who had. And they just wanted to know, were they as likely to form an immune response, and were they more likely to have bad side effects? And really, they didn't find that. The only thing that they found is there might be a little bit more muscle pain, and that's really it. So we don't know for all therapies, but at least for this targeted immunotherapy, getting a vaccination if you have cancer and you're on this therapy should not be a problem. We worried about it because, as you can imagine, an immunotherapy is revving up your immune system. And so if we're then asking your body to rev up around the COVID-19 vaccine, are we going to do some damage? Are we going to make you feel sicker? And we didn't really find that. And then I just want to make you aware of some very interesting studies that are going to really teach us a lot more about the safety of vaccination in cancer patients. This is a prospective study in the Netherlands that'll recruit about 900 adult subjects to receive the Moderna vaccine this time in 4 cohorts: individuals without cancer, and then people with cancers with solid tumors receiving either immunotherapy, chemotherapy, or chemoimmunotherapy. And basically what they want to know is what is the immune response in patients who are getting these vaccines? What are the side effects? And then what is going on in the T cells? Because we really also want to know, how long does it last? How frequently do we have to booster shot, especially in people who might be having, repetitive injuries to their immune system as they're receiving chemotherapy. So there's some interesting stuff that's going to come out and going to change our understanding. So really, where do we go from here? As I said, this has been a whirlwind of an experience for all of us with the pandemic. And like I want to take you back to those first set of slides, the context for this, right? The context is that these coronaviruses have been with us forever. They are in the environment. There are many, many kinds of coronavirus within bats and other animals. And we know now that these spillover events have happened and will continue to happen. So this is not going to go away. And there are going to be recombination events and new emerging viral strains. And I don't want to scare anybody. I'm just trying to get us to think about, okay, this is our reality. As science emerges, we understand more about these things that have always been in our environment. And now we're going to learn more about how to take care of them. So you're all very aware of the different variants of concern. Right now in America, the CDC feels that we have these variants under control, and that's largely because of using these safety precautions like masks and distancing, and also getting vaccinated, right? But there are lots of people thinking about how will we manage cancer and cancer therapy going forward. And these are probably some of the pillars of things that we're going to have to do in the future to ensure that our cancer patients get the best outcome and reduce their risk. So what does that mean? We're going to focus on treatment with the greatest benefits. So if you're going to risk potentially being immunosuppressed or potentially at greater risk because of the treatment that you're receiving, we're going to focus on those treatments that are worth the risk, right? We're going to adapt existing regimens to make them less risky for you to receive. We're also going to encourage vaccinations and keep building new vaccinations and finding ways to limit the exposure. We're going to avoid hospitalizations and prevent things like pneumonitis and hopefully lung metastases that may put you at greater risk should you be exposed to COVID-19. And then lastly, we're probably going to practice medicine differently. So I wonder how many of you have had telehealth visits, because of this, and who may in the future be wearing, a smartwatch or using a smartphone to tell me what your blood pressure is or what your lab values are, so you won't even come in. More and more of our care may in the future become home-based to keep you safe and to allow you to isolate in a safe way. So I'm sorry I'm a little bit over as well, but I'm curious to hear your questions and what your experiences have been like as potentially as a cancer patient who's had treatment during COVID-19 and maybe even had COVID-19 yourself. So those are those references, and I'll stop there and stop sharing.
All right, thank you. That was excellent, and I learned a lot. I hope everyone else did too. There are a few questions posted into the chat. I think just the panelists can see them, but just so to note, so we're obviously happy to answer any questions you have, but we can't provide medical advice, at least in this forum. So some general questions, yes, that's why we're doing this. But if there's any questions specifically related to your personal clinical care, then I would really strongly recommend contacting the clinic and the providers who you saw. or I mean, if you've not been seen and you're interested, then of course we can help facilitate that. But to do that through the clinic and the usual clinic contact route or methods. So first, the easy question is this being recorded and will it be posted? So the answer to both of those is yes, it is being recorded and it will be posted. We're going to wait. So some of the data actually that Dr. Lagers just presented, we have to wait a few weeks before we're actually allowed to post it publicly. But in probably early or mid-June, we'll post it online, and the SCCA folks, probably Ritu, will send out the link and how to get to it. So let me scroll through some of the questions here, and I'll just go one by one. So will interventional radiology be used for palliative? And sometimes it can. So that's where we get to the very personalized approach and sort of what are the symptoms that we're actually trying to treat and what are the other methods of getting at, especially symptom relief, if this, so the specific question was for palliative purposes. And it certainly, it can, and that would really depend on the specific case and what the circumstances are. Let's see here. Should I get the COVID test? So I think, or the COVID vaccine? I mean, yes, is I think generally the answer to that question for anyone who is eligible to get it. So as Dr. Lagers just mentioned, so it does seem like there's some heightened risk in patients with cancer in general, and that includes patients with sarcoma. But you know, COVID is here with us, and I think the way to get over this sort of, you know, stay at home and Zoom everything that we've all experienced for now more than a year is to get vaccinated. And you've just seen, so the CDC just changed their guidelines where vaccinated people don't necessarily have to wear a mask, which is a step forward. There were some questions about some specific types of sarcomas, so epithelioid sarcoma, leiomyosarcoma, what does that mean? So those are just specific types of sarcoma, where historically, we just, as oncologists in the oncology community in general, used to lump a lot of different types of sarcomas together because we didn't know any better. We didn't know what the differences were. But now that we're learning more and more about the science, we are able to actually give different names to different types of sarcomas. And that's important because sometimes it can have an impact on treatment. But that's a distinction that the pathologist especially is helpful in making. Let's see here. So I'll let I don't know if Dr. Lagers can see the questions, but I'll let her answer this one. So the question is, do we know how chemotherapy influences the effectiveness of COVID vaccines? Oh, you're on mute.
Sorry, I'm muted. Unfortunately, we really don't. You know, that's the difficulty, is that we don't know how it affects it. And that's the reason for studies like VOICE that I showed at the end there, is to really get that data to understand if it does affect it or not, and then what to do about it if it is affecting the effectiveness of the vaccine.
Mm-hmm. Yeah, and then so actually I'm looking at some of the more recent questions, and there's actually a number of, this is why we included this talk, a number of questions about COVID and sort of what practices. So instead of reading each question individually, and Dr. Lagers, I'd be curious to hear what you say. You did mention this some in the talk as well, but move forward. So especially with the changes in the CDC guidance and now more and more people getting vaccinated, what precautions, if any, should patients with sarcomas take? So should people still wear a mask indoors, even though the CDC guidance has changed?
Yeah, you know, I think if you were looking at kind of the community's response to CDC's change in guidance, there was a lot of well-respected virologists and infectious disease folks who said, well, you know, it depends on how comfortable I'd feel, right? If I'm going to potentially be in an environment where there are a lot of people who are not vaccinated, I might still want to be careful and still wear my mask, particularly if as an individual, you know that you're in a time where you might be more vulnerable, you know, for example, where your counts might be low, and that kind of thing. So I think, you know, we want to be clear on what the CDC's guidance was, which is that you do not have to wear a mask if you've had both vaccines and you are 14 days out from the Moderna or the Pfizer, or similarly, you know, that distance out from the single J&J. But the point is that cancer is its own special experience, and I'd recommend actually being, you know, caution is the better part of valor here until we really know, because you can't take it back, and you are at, you know, if you have active cancer, you are at greater risk. So as far as we can tell from the data that we have, so I would say, you know, be thoughtful about it. If you're outside and there's no one around you and you want to take that mask off and enjoy the sun on your face, of course do. But if you're going to be around others and you don't know their vaccination status or how they are, you know, behaving, I'd say be thoughtful and cautious. And then I see another question about antibody testing, and that's correct. They're not recommending antibody testing, and it's not all that easy to get. We're all going to just learn over time the best way to manage that. I also see that there was a question about going back a ways about sotorasib. I feel like I can never say these things, especially not in person. This is a KRAS inhibitor. It is mainly being studied in non-small cell lung cancer. It's in phase 1 and 2 clinical trials, so this is not FDA approved yet, and it's not approved particularly in sarcoma, but sarcoma patients could enter those studies. And we are not currently using the medication, and we're not currently participating in those trials, but I'd send you to clinicaltrials.gov to kind of look at that and see, you know, where that study is ongoing. Like I said, that's a very early study of a drug that, you know, as far as I know, doesn't have any proven benefit in sarcoma patients yet. But
yeah, so I'll actually add to that. So I actually had a patient with a KRAS mutation, and we do have that, or either that or a similar drug in our phase 1 group. So the difficulty though is to be eligible for that trial, specifically because we think the people who would benefit from that drug have to have a very specific mutation. And it's just not something that is very common, really by any definition of common, in sarcoma. So I don't think I've ever actually seen someone with that particular mutation. But you know, for the folks who do have it, it's actually a very potentially effective drug. Let's see here. So there's a few questions. So so the analogy, at least in the question, was moles can sometimes become more aggressive and develop into things like melanoma. Is there something along those lines with sarcoma? And that's a good question. It's a difficult one to answer because there are lower grade tumors that can sometimes evolve and become higher grade tumors. And that's why even if someone has a low-grade sarcoma removed, we would still do some sort of surveillance for them. There's not really that perfect analogy where something that was completely benign, like a mole, can change and then become a more aggressive sarcoma. In terms of new treatments, and the question specifically is, are there any new treatments for undifferentiated pleomorphic sarcoma? So again, a very good and interesting question. And the answer is, in clinical trials, potentially there are. So undifferentiated pleomorphic sarcomas might actually be more responsive to immunotherapies, but we're still studying that. So there are some clinical trials specifically aimed at undifferentiated pleomorphic sarcomas because of what we're now learning about the biology. Let's see here. So this is a question that will come up actually pretty frequently. So just how fast can a sarcoma be analyzed after it's removed? Where does it go? Who actually looks at it? And you know, how or why really does it take so long to develop a treatment plan? So to very quickly give an answer for that. So I can't do that question justice in the 30 seconds that we have to close out the Q&A, but that's something that comes up a lot. So I'll give it a minute or so. So what happens when you get a biopsy? So you get a biopsy, and then where does that sample go? It actually gets sent to the pathologists. The pathologists then process it. So they actually have to take that tissue and fix it in a way that will preserve the tumor or whatever the sample is that they've taken. And then they will embed it usually in a special type of wax. And then once that hardens, they can then cut it in little slices. And then they have many different stains where they'll actually stain different slices of that sample to see what proteins it has and what are the characteristics specifically of that particular tumor. And then they look at it, just literally look at it under the microscope and say, based on the way this looks, this is the type of sarcoma we think it has. Sometimes based on the way it looks, they'll actually want to do a genetic test. And then when they do that, that can actually add some time. So that process, even just of taking the biopsy, processing it, and then looking at it by the pathologist usually takes at least a few days. But then if extra tests on top of that have to be done, then that can add sometimes even a week or more, because they have to get DNA out of that sample, make sure that the DNA is good enough quality, and then actually do the sequencing. And then the sequencing data is actually an enormous data set where there are special software that can help analyze it. And that whole process, really at a minimum takes about a week or so. Depending on the testing that needs to be done, it can take even longer. And then we review it once that testing is done as our in our larger multidisciplinary group, usually in the tumor board conference. And then we'll ultimately develop a treatment plan that we'll then discuss with a patient and talk about what the different options are. So let's see here. Okay, so again, I just want to reiterate. So there are a few questions here that are again asking some more personal questions about people's specific sarcomas, and I just want to reiterate that those questions really should be directed to the clinical team who have seen you. And if it's us, then we will answer them in due time. But definitely contact the clinic because there's actually I would say a higher number than I thought questions like that coming through. So we'll have another session for questions at the end, but I want to move on now and let, who's next? Joe, I believe. Yeah, so Joe McNeal, who is a phenomenal partner for us, and then especially for patients with sarcoma, especially in the Pacific Northwest. So she's the executive director of the Northwest Sarcoma Foundation, and will give just a brief talk about that foundation right now and sort of what services they can offer to patients with sarcoma.
Thank you. I'm your non-clinical break, medicine break for the moment here. Hopefully everybody can see my screen. So yeah, I am the executive director with the Northwest Sarcoma Foundation. And we are, hopefully everybody can see my screen, thumbs up. Thank you. Okay, making sure. We provide hope, education, and support to sarcoma patients and their families in the Pacific Northwest while investing in sarcoma research. So we've invested funding with SCCA, University of Washington, and a few others. So we're very excited about that. All right, so I'm going to hopefully move my screen forward and you'll be able to see that. Tell me you've got that. I want to make sure because I'm like, did it move forward? Please tell me. Okay, thank you, Ritu. All right, so most of you may be familiar with our patient helps grants called the Jenna Westerholm Pediatric Foundation Grant and then the Foundation Helps Grants. This organization is a very unique organization in which we provide financial grants to patients. Many of you may have been an actual recipient of some of our funding, and we've during COVID did a reduced amount. We're excited to announce we're actually increasing that back up to match what the adult grants were, which is 500. And the Jenna Helps is matching back up to 500, and we hope to restore it back to its original at $1,000. Prioritization is given to current treatment patients currently in treatment, and financial needy. And all of this must be done and requested by your social worker or a patient navigator. So if you have questions about eligibility, please contact your social worker or patient navigator about our HELPS grants. And then a new program, well, reinstated program, is our care packages, and this is for everyone. So if you are a sarcoma patient, adult, teen, child, or a survivor of a sarcoma angel, we are now producing and putting out care packages. So we obviously have some items that are donated. People have done some things through Amazon Smile. We're still searching for things, but if you have an opportunity and you want to know more, again, go through your social worker or your patient navigator. So we are excited to actually bring that program back. Moving forward, we've actually added this in December of 2020, we added our casual chat groups. We have 3 different groups. One is for adult patients and survivors, which we casual chat. We have one for caregivers, and we have one for survivors of sarcoma angels, meaning if you have lost someone to sarcoma, we have a group for them also. So those happen in different times, and you can always find more information about them on our website. And other than that, we have some upcoming events. In fact, a week from yesterday, we have our first golf tournament, and it's our first in-person event in over a year. So we are absolutely excited to be coming back in person. May 21st, we have Swing for Sarcoma at the Nile Golf Course. So if you're a golfer and you want to get a foursome together, please consider joining us. You can find a link again on our website to register for that event. Another thing we do is virtual researcher update nights. Dr. Wagner was one of our first speakers for that, and he did a wonderful job. Dr. Loggers is actually going to be coming up in October of 2021, but our most recent one will be Dr. Laura Villalobos on June 8th, and she is out of the University of Washington's Vaccine Institute doing research on liposarcoma. Dragon's Last Ride motorcycle event, July 10th. Our biggest event of the year, which we encourage all of you to come to, is our Dragon Slayer walks. You can see we have one in Portland. New this year is Spokane, and then Seattle is on September 25th. So at Magnuson Park. So we encourage you to come join us at that. And then we are hoping to reinstate some of our other events in the future, which are all dependent upon COVID opening up. So we'll see how that goes. And then obviously, we have some corporate partners. One of them is Seattle Cancer Care Alliance. Thank you, guys. And other than that, we also have things like Immerman's Angels, which does peer-to-peer one-on-one matching for sarcoma, all cancers, and they match globally. So if you have a very unique cancer, Immerman Angels will do a peer-to-peer match and try to match you up with somebody who you can speak with. So you can always find them at their site. And then some of the other ones we do partner with is like Elephants in Tea, which is a young adult group that meets so regularly to kind of talk about things. Your team, I have Chelsea, who is down in Oregon. She's my director of programs, obviously myself. Annie, who is our admin assistant. And then we are now searching for a new team member for development coordinator. We're very excited to be expanding. You can see our board of directors are very active, very passionate about this organization. And lastly, we make sure that no one faces sarcoma alone. And that is most of our board members. The picture was taken prior to some new board members coming on. So we just want to be there for you. And we look forward to hopefully seeing you at our Dragon Slayer walk. And if there are questions, I will certainly answer them during the Q&A later on this afternoon. So thank you, everyone. I'm going to stop my share with you and we can move on to the next step. I hope I saved some time up for you guys.
Thank you. That was excellent. We're
You're
now
welcome.
just 1 minute over. So I think I'm the biggest offender there. So we're gonna change course a little bit, and now the next speaker is going to be Kathleen Sanders, who is a nurse practitioner at SCCA, but she's going to talk about integrative medicine and then also relaxation techniques, which are, or at least can be, very helpful for patients and caregivers. And without any further ado.
Hello. Hi,
there you
can
are.
you hear me? So good to be here. Thanks for inviting me. And I will share my screen, hopefully. Let's see. Rudy, I thought I had been so prepared here. Let's see.
Would you like me to share your slides?
No, I think I'm good. I'm getting
Okay.
there. Sorry for the delay. Yeah.
No problem.
There we go. Okay. So I'm here to talk about integrative medicine from our view of integrative medicine and also about our program. So we have a wonderful team. Dr. Greenlee, Heather is our director, and she is a naturopathic physician and a public health researcher. Her main focus is on nutrition and exercise and cancer.
I'm sorry, can I just ask one question? Can you put it, I don't know if other people can see it in full screen.
No, it's not on full screen, actually, Kathy.
Oh, okay.
Okay, I think if you just hit presentation mode on the bottom.
Mm-hmm.
There's all the way on the bottom right.
Ritu, do you want to go ahead and do it since I'm
Sure.
fumbling right here? Okay,
Sure.
sorry about that.
No
Okay.
problem. Can you stop sharing, Kathy, so I can share my screen?
I will do that. How's that?
Yep.
Right.
So
There. Okay.
okay.
Okay, great. Thank you.
You're welcome.
Do I have control of the slides or do you?
You'll have to tell me to advance, which is fine.
Okay, next slide, please. Thanks. So I just wanted everyone to get a sense of our team. And we have 3 acupuncturists now. Our Kathy Taramina came on board a few months ago, and they're all very experienced in oncology. We're very lucky to have all of them. And Sarah Schaefer is our service line manager. If you go to the next slide. So my background, I studied with Dr. Andrew Weil's program in Arizona. I did a 2-year fellowship in integrative medicine about 14 years ago now. And have been working in that arena since. One of my biggest skill sets is around mind-body medicine techniques, and I'm trained in a number of them. I've been doing telemedicine actually since last March, and have been able to successfully work with patients with the mind-body techniques. And I'm also trained in auricular acupuncture, and so teaching acupressure, and I'll talk more about that. So next slide. So I'd like to talk about what integrative medicine is, since I say often it's kind of the Wild West out there, and there's a lot of different interpretations of what that means, and I'll be talking about it from our view, how to use it for optimal health wherever you're at in the continuum, and a little more about our program. And then I'd like to do an experiential with some of the relaxation techniques that I teach. Next slide. So we all belong on our team to the Society for Integrative Oncology, and this is the definition that they use for integrative medicine or integrative oncology. And so it's patient-centered, evidence-based field of cancer care that utilizes mind-body techniques, natural products, lifestyle modifications from different traditions alongside conventional cancer treatments. Our view and our aim and our vision is to optimize health, quality of life, and clinical outcomes across the cancer continuum, and to empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. So we know a lot of people use supplementary, complementary, alternative therapies. And we want to be here to really help people look at all of those, see where the evidence is, see what's safe, what works and what doesn't work. Because people are getting a lot of information from a lot of different places, and it's people that love them, their friends and family, it's their own research. Sometimes I have people researching many hours a day, and I try to help them ramp that down a bit so they can do more self-care. But it's an area that still has a lot of gray areas in terms of what's effective, how and where the research lands. So part of our role is to help with that. But people are doing it for lots of good reasons, for survival, to improve their cancer treatments, to decrease symptoms, to hopefully help with comorbidities or other challenges they're having in their health, like diabetes, for example. Overall improvement of quality of life, less stress, and just to feel better overall. So lots of good reasons to do it. So we want to talk about what works, what doesn't work, and what's safe. I like to talk about this because I think we all have kind of an idea like, oh, I know what that is. I know what integrative medicine is. And really, it's a lot of different interpretations out there. So there are traditional therapies that have thousands of years, whether it's within Native American communities, traditional Chinese medicine are two examples. And then alternative therapies might be things like homeopathy or traditional Chinese medicine, where someone has decided to just do that and not use conventional medicine. Complementary therapies are literally those forms of alternative therapies that have evidence that can be used together with conventional treatments. And so our definition of that is evidence-based, complementary and supportive therapies in conjunction with conventional therapy. So this is our program at this point. We started building it about 3.5 years ago. And we are available to patients at any point from diagnosis to end of life. Our focus is truly on symptom management and quality of life. Patients can self-refer, as can all providers within SCCA. And we want to be a resource for clinical staff, for patients, for their caregivers, family, and also with Dr. Greenlee's research team provide patient-centered research on things. And there's many of them within this arena that we would like to see more research on. We're part of the supportive care network at SCCA and work together with everyone on this team. And I feel incredibly blessed to be at an institution that has such a strong supportive care team. I've really been feeling that during this last year, that people are very available, and we've really, really worked hard together to support patients. So these are the areas that we focus on when people come in for an initial consult. We do look at food as medicine, exercise and movement, and those both have a very deep base of research. I think sleep is one of the most neglected areas of health, and that's something I love to do a deep dive with people on the different self-care things that they can do to improve their sleep. We talk about acupuncture as appropriate. Not everyone is eligible for acupuncture. People that are challenged with white blood cell counts or platelet issues often aren't good candidates for that, but acupressure can be an option for that. And so we've really built our acupressure program over this year. And then mind-body medicine. And I'll be talking more about that. I think one of the core pieces that I talk to all of my patients and myself about is about letting go of perfectionism, that we need to be kind and compassionate with ourselves each day and really honor where we're at. And so all the things we're bringing up are not about eating perfectly or perfectly doing any of these things. It's about bringing it in a way that's sustainable in your life. So I like to talk about that, and I like to bring it up in presentations as well, because I think it's so important. So Dr. Greenlee and I are not nutritionists, but we do talk to people about an anti-inflammatory diet when it's appropriate. And but medical nutrition is its own science, and we have a wonderful team here. But Dr. Greenlee's research in Cook for Your Life with Ann Gaffney is a really beautiful website on anti-inflammatory diet. There's a lot of good resources out there. As we all know, food is not just about nutrition. It's not just about our cellular biology in our brains. It's about comfort, and it's about stress management sometimes, and it's about celebrating. And so having a diet that is mainly healthy, but then really enjoying those foods that are important to us in being in community, with our family and friends or things that we grew up with. I think that's really important. I am trained in something called mindful eating. For some people, they're really trying to make significant changes in how they approach food and how they're eating. And one of the mind-body medicine techniques that I teach is the mindful eating program. And the Center for Mindful Eating is a great place to go. I studied with Dr. Jean Christeller, who developed that site. And you can even just go to it yourself and practice some of those things. So it's a way to possibly change habits. It's also a way just to really enjoy your meals more and to get away from staring at a screen while we eat, or doing other things that are distracting. Next slide. So exercise, no brainer. Everybody knows it's important. I think the challenge is finding exercise forms that work if our energy is low, or if we're challenged in different ways physically. Prior to the quarantine, we did have a really wonderful therapeutic yoga teacher at SCCA, and we will again after this, but they can really adapt yoga for people in using a wheelchair or just very tired or having specific issues. So that can be a form of exercise that can be helpful. And then I try to get a lot of my people to do Qigong. Qigong can be really good for the circulation. It's very flowy. You don't need a lot of energy for it. And I provide a little web link for people to at least give it a try. And I'd have to say most people love it once they've tried it. So there are some forms of exercise you can do when you're feeling less energetic or less able. Or as many people would say, during the winter, when it was just a hard time to get outside, there are things you can do inside. And we do work with our physical therapy department. There's also a wonderful program at the Y and they are starting to open up again, called Live Strong for people with cancer. That's free. That's just an excellent, well-rounded exercise program. Next slide. So I do love to work with people on sleep. We know that good sleep really helps us physically. It changes our hormones. It probably affects, the indicators are it affects our immune system. It helps reduce inflammation in the body, and overall quality of life. So that is an area I like to work with my patients that are interested in working on that particular problem. As we know, it's a kind of an epidemic problem for everybody in the world, but especially in the United States. Next slide. So acupuncture is an important part of our program for people that are able to do it. It can be very helpful for a wide range of symptoms. And we do have really good research studies on a lot of these different, especially the top ones. If you could go to the next slide. And it's an area that Dr. Greenlee's team is going to be looking at more with our acupuncture team. For people that have some fear of needles around acupuncture, we wish they weren't called needles because they're like hair and they're just so thin. But anyway, that's something you can talk to us more about if it's something that interests you, but you have some concerns about that. When people come in, it's usually for a course of treatment, usually about 6 to 8 weeks, once a week. But we've also developed a referral source because a lot of people come from other areas. And we also have questions to ask if you do want to see someone in the community, because we want that person to be oncology experienced. Next slide. And then if you could just go down that list quickly, it just shows which, it has like a, yeah, thank you. So the ones at the top have the most strong randomized controlled studies on human beings, which is our goal with most of the things that we offer. The ones on the bottom have less. But because it can be so safe and because some people do get an improvement in energy, often it's worth trying. And in fact, it often can be quite helpful for those things that we don't have large studies on yet. Next slide. So dietary supplements, we have a very strong relationship now with SCCA Pharmacy and Nutrition, and we're actually going to be putting out very soon. I think it's been a 2-year project really working on dietary supplements and how which ones are safe, which ones have evidence, how they might interfere with different treatments. But it's a really important part of what we want to do with people is to really look at what they're doing. Pharmacy weighs in on safety. We talk about where's the research and where does this have value? Because often people are spending a lot of money on things that really don't have good evidence. When they focus, in our opinion, would be to work on those other pieces that do. Next slide. So mind body medicine is my passion, and it's something that has over 30 years of research now, and it's looking at how we think and how the brain has an impact on the body. And within the National Institute of Health, if you go to that site, there's a lot of information on mind body medicine techniques. Next slide. So it can be used for many reasons, and it's the bottom line with mind body medicine is it's very safe for everyone to do at any point. And it can be very helpful. And the indicators are that it does help the immune system. It does help with the reduction of inflammation. It can be helpful for pain management, certainly helpful for anxiety reduction. I work with a form of guided imagery for people that are very anxious pre-surgery, pre-procedure treatments, and it can be done to help reduce anxiety in those areas. Next slide. So I work with teaching breath work. I don't teach yoga, but that is a movement form of mind-body work. Almost all my patients get my passive progressive muscle relaxation recording. And so Kathy is talking people into a relaxed state all over Seattle. And guided imagery, mindfulness-based stress reduction, I studied with John Kabat-Zinn's group at the University of Massachusetts. And meditation has a spiritual component. So I often work with our spiritual health practitioners. Juliana Perez in particular has a strong mindfulness component. So that's a place where we do some nice collaborating. So I'd like to do some relaxation techniques now with you all. And for that, I'd just like you to get your body into a relaxed position. So feet flat, hands resting comfortably, maybe put one at the bottom of your abdomen. And if you're not comfortable doing it, that's totally fine. Just observe. That's also an option. And to start, I'd like you to breathe in through your nose, down as deep as you can into your lower abdomen, and then without holding, breathe out through your mouth. And we're going to do 3 of those. And then breathing normally, I'd like you to close your eyes or just have your eyes partially closed in a non-seeing gaze. Either works completely well. What I'd like to do first is called the lemon exercise. So it's an exercise that helps with this idea of how does the brain connect to the body. What I'd like you to do is imagine you're standing in the kitchen in front of a plate and a cutting board. And on the cutting board is a little knife, and I'd like you to chunk up the lemon, cut it up, smell the fragrance and see the juice. And then pick up one of those chunks and bring it up to your mouth and bite into it. Tasting the lemon and feeling the juice and smelling the fragrance. And then I'd like you to open your eyes. So it doesn't work for everyone. It happens to me every single time I do this. My salivary glands pucker up, and it does. So it's this idea that we can think and that we can actually physically change something, and this is very simple, but the salivary glands. The breath that I just taught you is a form of diaphragmatic breathing or soft belly breathing. Dr. Herb Benson from Harvard, it's been over 30 years ago, wrote The Relaxation Response, and that's one of his fundamental practices. And he has a institute at Harvard really looking at the relaxation response. So that breath actually engages that relaxation response. So it's something you can do throughout the day. And I'd like to teach you one more breath. It's called the 4-7-8 breath. And we're just going to do one round of it this time. But it's breathing in through the nose, and I'll count you through it for a count of 4, holding for a count of 7, and breathing out for a count of 8. So breathing in, 1, 2, 3, 4. Hold it, 2, 3, 4, 5, 6, 7. Breathing very slowly out through your mouth. 3, 4, 5, 6, 7, 8. Okay. So that breath is a stronger breath, and you should always do it seated or lying down. It's Dr. Andrew Weil's favorite breath, and it's very calming, and I like to use it before meetings, or if you're going into a situation where you're having a difficult discussion, it can be a very centering breath. So usually 3 at the most, but it's a nice strong breath. So the last thing I'd like to do, and you can do progressive muscle relaxation in a few minutes. You can do it in 10 minutes, but it is something that you can use as a tool throughout the day. So what I'd like you to do again is close your eyes, or imagine your eyes just half closed with a non-seeing gaze. Take a breath in through your nose into your lower abdomen, out through your mouth, breathing normally. And then I'd like you to bring your awareness up to your forehead and feel those little muscles stretching out and relaxing. And as thoughts come into your mind, I'd like you to gently acknowledge them and let them drift away. You can tip your hat to them in your mind or let them drift away on a balloon or a cloud. Now I'd like you to imagine that relaxation in your forehead flowing over your eyelids, over the bridge of your nose, into your cheeks, and really soften your cheeks and let your tongue and jaw be slack. We hold a lot of tension in our faces. And imagine your scalp loosening up and relaxing. And then bring your awareness down to your neck and shoulders and let any tension there dissipate. Imagine it floating away. And then feel that relaxation flow into your chest and stomach, diaphragm and abdomen. Feel that relaxation moving from the base of your neck all the way down your back. You can even imagine a soothing substance, cool or warm, flowing down the middle of your back, sides of your back, and your lower back. From your shoulders all the way down your arms, into your hands, fingers. Feel it flowing into your hips, your thighs, your knees, your calves and ankles, your feet, and your toes. Imagining now any tension or tightness that's left in your body flowing out the bottoms of your feet and into the earth. All the muscles in your body now are so relaxed, comfortable, and at ease. Take a moment to notice the stillness that's there. The more you're aware of that stillness, the deeper and more healing your relaxation becomes. Now take a nice deep breath into your lower abdomen, move your fingers and toes, and open your eyes when you're ready. So love to hear how that went. I'll be here for the question and answer period afterwards. So that's a foundational practice. And our goal is that healing can happen at any point, and all of these things can contribute to that healing. And it's so glad, I'm really happy to be here and be included. So thank you very much.
All right, well, thank you, Kathleen, very much. That was, I hope, a good experience and useful information for everyone. And I'll leave the screen up just for a second, but if anyone has any specific questions or wants any of these resources, so just to remind you, so all of these presentations will be posted, but there's going to be a little bit of a delay, so of at least a few weeks before we actually get it posted onto our website, but all the presentations will be made publicly available in the relatively near future. There will be one more question and answer session at the end. There's just one more talk, which is going to be me, and for another shift in gears again, I'm going to be talking about sarcoma research and what are some of the things that are ongoing right now, and then also to some extent at least, what are we to expect in the future. Actually, can you, thank you. So now I can share my screen. Okay, so I'm going to talk just at first in general. So what even is the research process? Some of this actually overlaps with the talk I gave back in November. So if anyone was there, I apologize for the duplication. But first, what is research? And research is actually a very broad term and can mean lots of different things. And in general, at least for cancer research, there's sort of three overall areas that we think of. So first is basic research, and that's really getting into the science of how do cancer cells grow? What genes are activated? What proteins are they expressing? Oftentimes this uses animal models, so mice is probably, or mice are probably the most common organism that we'll use, but sometimes even zebrafish are used. So not so much in terms of testing per se, but actually sarcomas are relatively common in dogs, and there's even some labs out there that use people's pets who have developed sarcomas to do clinical trials even in dogs and to take those tumors and even study those in the labs. And sort of that basic science part is where we try and identify what are the targets for drugs. So, what protein do we want to block with either a pill or an IV infusion to try and stop the cancer from growing. And then on a little bit more clinical side, but still very sciencey, there's translational research where for translational research, we try and figure out, can what we've learned in the lab actually be seen in sort of the human condition of sarcoma or cancer, where we think what we're seeing in just cancer cells that we're manipulating with pipettes and on a lab bench is relevant. But there's a lot of changes and a lot of differences that can happen when you remove the cancer cells from the person or the individual where they started in, because we're all very complex and cancer is no different. So we want to actually know, is what we're doing in the lab relevant and potentially applicable to the human condition? And we sort of along those lines doing translational research, and this is sort of in the clinical trial part of it, where a lot of clinical trials will actually require or at least request that biopsies be taken. And we can actually use those biopsies to then go back and look at those samples in the lab. And sometimes there are differences where we can see, especially if we know what happened clinically with a patient. Did the drug work or did it not work? And then we can actually look at the tumor and see if there's any differences that might help us differentiate what to expect if we use that particular drug, or even what to expect just in general if there are certain changes in the genes or in the proteins that might make a cancer for whatever reason more aggressive or less aggressive. And even though there's sort of those three overlapping broad areas of research, it really is a continuum. And we will take things from the lab and then move them into the clinic, but then we also go backwards. And just in the example that I said, where if there's biopsies from a patient and we know what happened from a treatment, we can then go back and use that clinical information and then actually target what we're doing in the lab or in sort of whatever the research setting is. And there were some questions actually posted in the last question and answer session about, how long does it even take for an identification of a gene or identification of a protein to be discovered to then eventually turn into a medicine? And it actually takes a very, very long time. And years is sort of in the best case scenario, where there are basic discoveries that happen in the lab, and it usually takes many years to confirm those discoveries in other experiments, and then usually even in other labs, to make sure that everyone's getting the same result. And then after a while, there are big drug screens, and the drug companies do these things all the time. But they can test thousands and thousands and thousands of drugs trying to see what of the drugs that are available, and sometimes they'll develop new ones, what actually leads to the change that you want to see the best in the lab. And then once all of that is done, which really at a minimum takes at least a few years, usually longer, then we can actually start doing clinical trials. And clinical trials also take a very long time. They're very expensive. They require, as much as possible, at least relatively large numbers of patients, because we want to make sure that what we're actually doing is safe. So safety, especially in the phase 1 studies or the early stage studies, is really one of the priorities, and really the priority, before any particular drug is given to a larger number of patients. And then in the later stage, or the later phases of clinical trials, that's where we really are asking, does this drug work? Does it make people live longer? Does it actually shrink the tumors the way that we want it to? And hopefully it's doing both of those things. And then even after a drug is approved, we're still learning. So we still see side effects that might come up that, even if they're relatively rare, you absolutely want to know about. And then sometimes, and I'll give an example in a little bit, sometimes a drug might be approved, but then a larger study can show that actually what we thought was true might not necessarily be the case. And all of those questions are studied in very regimented, very regulated ways, where there are very large government agencies that oversee the way clinical trials are run. And you've probably heard of different phases of clinical trials. And that's the way historically clinical trials had been, where it used to be a target was identified in the lab, lots of different drugs, I'm going to go back, so lots of different drugs would be tested on that target. And then once one or a few drugs were selected based on what was seen in the lab, then a drug would go from phase 1 to phase 2 to phase 3. It's not quite like that anymore. We try to minimize the number of trials that are needed, but by doing that, we're also trying to shorten that time frame. Because if we have a drug that's especially promising, we don't want to wait 6 to 7 years to actually get it to a point where it's approved and more widely available. And that's something that we collectively as a medical field have been working on, and to some extent struggling with, because we don't want to compromise patient safety either. So what we're trying to do is shorten the time period to get good active drugs more widely available, but still also make sure that we're ensuring the safety of patients. And safety really is the main thing that phase 1 studies are developed to look at. So phase 1 studies are usually for drugs that have not really been tested in people before, or they have been tested, but not in a particular disease. And they're generally fairly small studies where they'll actually usually require many different blood draws and lots of different clinic visits, because we want to see you. We want to make sure that there's no toxicity that this drug is causing. If we see activity with it in a phase 1 study, that's obviously great, and we want to see that. But safety in particular is the priority for studies in phase 1 specifically. And then once we know that a drug is generally safe, that's when we can give it to larger numbers of patients. And usually, and then certainly historically, the next step of that would be a phase 2 study. So phase 2 studies are designed to specifically look and see, so we know that this drug is now generally safe. Is it active? Does it lead to the change in the cancer that we want to see in patients? And there's a few different ways these can be designed. Many of them, and especially in sarcoma, are what we call single arm studies, meaning that every patient who goes on to the study will get the drug. And with the help of our statisticians, we will know. So if we put, for example, 12 patients onto the study and a few of them have a response, then we can actually expand the number of people to try and get a better picture of, what's the real activity of this particular drug, whatever it may be, whatever we're testing. And then once that's done, then we'll go into a bigger study. There are some phase 2 studies that are actually randomized, either to a placebo or to a different medicine, like a different chemotherapy that we know is active. And sort of the difference between a phase 2 randomized study and a phase 3, for the most part, is really just the size of it. So there's some statistical differences, but really the bottom line is a phase 3 study requires many, many more patients than even a randomized phase 2 would study. But usually the FDA will want to see a randomized phase 3 study before they'll give a final approval for a drug. Now you'll see actually that there are drugs approved based even just on phase 2 studies. And that's because if we're seeing a lot of activity, then people want it. So doctors want to be able to prescribe it. Patients read about the clinical trials and understandably very much want to get access to those drugs. And if it's not approved, we just can't prescribe it because it's not available. So what the FDA is doing more and more frequently is actually giving what's called conditional approvals. And the condition of that approval is that the activity that was seen in the earlier studies has to be confirmed in a larger phase 3. And that's really what those larger, usually multi-center, meaning it's open at many different sites in the country and sometimes even in the world internationally. That's what those large phase 3 studies are for. There's different settings where clinical trials can be organized from. So especially in oncology, cooperative groups are actually very important. So there's a number of cooperative groups that are focused on developing clinical trials for patients with cancer. So I've listed a few of the bigger ones here. So SWOG, or the Southwest Oncology Group. The alliance is literally an alliance of a number of mostly academic centers where clinical trials can be organized through them. SARC I highlight specifically because it's actually a sarcoma focused cooperative group. And they provide a few things. So one is the just logistical support for a clinical trial, but then they also allow us to open clinical trials at a number of different sites, which is good for many reasons. One is because it makes the trial and therefore the drug more widely available. So you don't necessarily have to be in Seattle to get all of the clinical trials that we offer in Seattle. Some of them are open at many different sites, and it's the same trial and the same drug, regardless of where you are, as long as it's the same study. And they also provide support and help us work with the government, because a lot of these trials are actually funded by the government, where either a drug company or the National Cancer Institute will actually have to provide the drug because it's so expensive that we literally just can't pay to run a clinical trial on our own. So we need these collaborations to make progress and to actually do the studies that are needed. Some of them are industry sponsored. So again, these drugs are very expensive. Running trials is very expensive. And in order to get the drug approved, the FDA requires, for understandable reasons, that there be data showing that the drug is actually effective. So many of the industry sponsored studies are ones that the company has to do in order to actually get a drug approved. And then there are some studies that are what we call investigator initiated, where these are studies where people like me, people like Dr. Lagers, have an idea based on information that comes out of the lab. We say, hey, this looks like a really exciting gene or an exciting protein or finding that we're seeing in the sort of lab specimens that we have of various sarcomas. And we think that by targeting that protein, it might actually work. And we can actually float that idea to drug companies. We can float it to various organizations. And then sometimes clinical trials can actually spring off of those ideas. Usually we would do that in cooperation with either a company or a cooperative group, again, because somehow the trials have to be funded and they can help provide the funding and logistical support for it. With clinical trials, because they're so regulated, there's a predetermined number of spots that we're allowed to put patients on. And it is somewhat fluid, where there could be open availability one day, but then a week later, there might not be any more slots. And then we might just have to wait until we know that all of the patients who have already been enrolled, who got the drug especially, did so safely and that there was no unexpected toxicity. And then sometimes more slots can open up after that. And the specifics of that really depend on the specifics of the clinical trial. What's the goal of it? What's the number of patients who are sort of predetermined to be allowed to go onto that study? But through all of that, really, patient safety is the priority. So yeah, we want, just as you want, to make all of these drugs available to everyone. But sometimes toxicity does come up. And what we absolutely don't want to do is to think that something is effective and to think that everyone's going to be helped by getting any particular drug, but then actually sort of inadvertently cause a lot of toxicity, because that would not be helping anyone. As far as clinical trials for sarcoma specifically, some of them are general for really any soft tissue sarcoma. I think would be the most common general sarcoma trial, where there are drugs that we think might actually work for different subtypes. But now that we're learning more and more about the specific sarcomas and what makes each individual one grow and survive, we want to more smartly develop drugs and also more smartly design trials to really only allow patients to go on who we think are the most likely to benefit from those particular drugs. I think just as an example, so we know that imatinib works really well for gastrointestinal stromal tumor. So as we're developing trials for gastrointestinal stromal tumor, we don't allow patients with GIST to go on to clinical trials with chemotherapy, because chemotherapy doesn't work in that disease. So that's just one example of how we design studies to try and maximize the benefit to the patients, but then also minimize the risk. And just as an example of something that was actually very prominent in the sarcoma community even just a few years ago. So olaratumab, or Lartruvo, was a drug that many of you probably even received, where there was a phase 2 study, which was actually a relatively large phase 2 study that was randomized, where people either got doxorubicin alone, so the chemotherapy alone, or the combination. And what that study showed was that the people who got the combination actually lived a year longer on average than the people who got the chemotherapy alone, which is really a remarkable finding. So with most drugs in oncology, we don't see that magnitude of a benefit. And that was such a striking finding that the drug actually was approved, but with a conditional approval, where the FDA said, this is a really great result, but you still have to confirm with a larger phase 3 study that this finding of a survival benefit is actually real. And sort of in that period between when it was approved and then eventually it was taken off the market, the combination was the standard treatment for most patients with metastatic soft tissue sarcomas. But then in 2019, that larger phase 3 study was completed and the results were finally made public. And what that actually showed was that the people in the combination arms, so the people who got the Lartruvo or the olaratumab, did the same, meaning they lived just the same amount of time as the people who got just the doxorubicin, just the chemotherapy alone. So that what we all thought was a very encouraging result in that phase 2 study turned out just not to be the case when we looked at it in a much larger group of patients. So what did we learn from that? So first, we still need to find better treatments. We're still working on it, and I'll talk some more about that. But clinical trials are critical. So there's information, really, especially with the internet, in all sorts of places. Some of it is excellent quality, some of it's not so much, but even good quality data, sometimes we have to take with a grain of salt, because the data is only as good as the information that sort of led up to it. And that phase 2 study was actually a very well done trial, but it was small and ultimately turned out to lead us astray a little bit. So when we talk about big clinical trials and when things are placebo controlled, this is why we do it, because we really want to learn, are these drugs actually doing what we think they're doing and what we want them to do? And clinical trials is the only way to truly answer that. So to shift to a more positive note, so a few years ago, the Nobel Prize in Medicine was actually given to 2 scientists, one in Japan, one in Texas, who discovered that there are certain ways that we can manipulate the immune system to actually fight against cancer. And this has just truly revolutionized the way a number of cancers are treated. And that's a revolution that is still ongoing. And the Nobel Prize was just in 2018. The first drug approval with this type of medicine was just about 10 or so years ago. So within the past 10 years, the treatment of melanoma, lung cancer, certain types of breast cancer, certain types of colon cancer, bladder cancer, kidney cancer, have all completely changed from how they were managed even just 2 decades ago, all for the better. And what they discovered was that our bodies have ways of trying to protect ourselves from our own immune system. So of course there are autoimmune diseases, so things like type 1 diabetes, inflammatory bowel disease, rheumatoid arthritis. Those are all diseases where our immune system actually attacks our own normal body cells. And that can happen. And cancers actually have developed ways to fight against our own immune systems. And they harness ways that our own body tries to protect against our own immune system, in that if our immune cells were just going around attacking everything, we'd all have autoimmune diseases, but we don't. And why is that? It's because we have these proteins called immune sort of checkpoint inhibitors. So some of the more common ones, or really the most common one that you've probably heard of, is a protein called PD-1, which then will bind to PD-L1. And those proteins can be on lots of different types of cells. So when that protein on the T cell, so on our own immune cell, sees that on one of our own other cells, that tells that immune cell, don't attack me. And when that's there, that's why we don't all have autoimmune diseases, because in sort of the normal state of things, our immune system will recognize our own normal cells. And the cancer takes advantage of that. So that in the picture that you can see, the cell on the top right is a cancer cell, and that's expressing some of the same proteins that our normal cells would otherwise express. And when the T cell or the immune cell sees that, it doesn't attack the cancer. And what the drugs do is they actually disrupt that interaction. And when that interaction is disrupted, then the T cell can then, at least hopefully, attack the cancer. And that's been revolutionary for many different types of cancer. And we're now still learning more and more about this. And a number of years ago, there was an effort to actually see, so what is the number of mutations that each individual cancer type has? And the reason that's important is because when a cancer has more mutations, it's more likely to be recognized by our own immune system. And we think that those drugs that have been developed to target the immune system are more likely to work if there's a lot of mutations. And what this chart, it's kind of complicated, but what it represents is all the way on the right, those are cancers that have a very high level of mutations. So things like melanoma, lung cancer, bladder cancer. And if you think about it, they have a lot of mutations because they're actually caused by various things in the environment that damage DNA. So melanoma, at least in part, is caused by DNA damage from UV light exposure, just from the sun primarily. Lung cancer, of course, there's damage from smoking. Bladder cancer, so your bladder is where the urine is stored, and the urine is sort of the result of your body filtering out various toxins. So over time, your bladder is actually exposed to various things that you ingest that your body's trying to then get rid of. And those are the cancers that seem more likely to respond to these immune therapies. So where does sarcoma fall on this spectrum? Sarcomas in general, if we were to make one statement about all sarcomas, actually have a very low number of mutations. So Ewing sarcoma, you can see, of all the cancers listed here, is the second to last. And rhabdoid tumors, which is actually a variant of sarcoma, is the lowest. So even though these drugs have been very successful in other cancer types, we're still trying to figure out what are the subsets of sarcomas where these might work, and then how can we make modifications either by other combinations or just trying to otherwise change the way that these cancers show themselves to the immune system to make these drugs work. And there have been a few studies, this slide's a little bit outdated, but it gives at least a sense of the overall picture of what happens if you use these immune checkpoint inhibitors in people with sarcoma. And I am highlighting just 3 studies here. Again, there are more, and this is a little bit outdated, but we're seeing some activity in some patients with sarcoma. It's just that it's not as common as what we would expect in some other cancer types. And some of the types where we've actually seen activity are, so there's a few isolated cases with leiomyosarcoma, but that's really all that we've seen with leiomyosarcoma. There are some bigger studies that have shown very, very little activity for that diagnosis specifically. So someone in the last question and answer session asked about undifferentiated pleomorphic sarcoma, or UPS. That's one where it actually does look like probably a relatively higher percentage of people might benefit from the immune therapies. I'll show some data that we organized, or really with a trial that I was the lead of in angiosarcoma specifically. But there are some isolated reports of, for example, patients with osteosarcoma, chondrosarcoma, who have responded. It's just that on average, these medicines tend to not work. And we're still trying to figure out why exactly that is. When they do work, though, they can work very, very well. And this is, again, a complicated graph, but what this is what's called a swimmer's plot, where each horizontal line represents an individual patient who was on one of those clinical trials with the immune therapies. And the length of that line represents how long was that patient on the study and how long were they actually getting that drug. And for the patients on the top, those are patients who got these immune therapies. The top 2 actually had responses. And if you look at the x-axis for just how long did this last, they were on the drug for over a year. And the 3 patients on the top, at least at the time the study was published, were still getting that same therapy, still with benefit. So clearly there are some patients who benefit from these types of immune therapies, but it's a relatively small number of patients, and we're still learning how to figure out who are those individuals who are more likely to respond. Because if we knew that, then we would want to use these drugs in those patients, because when they work, they do actually tend to work really well. And they're also generally more tolerable than a lot of the other medicines that we use. They can have side effects, but it's not guaranteed to have the nausea and the fatigue and all the other things that you would typically associate with the chemotherapies that we use to treat sarcomas. This is just an example of a patient who was treated here in Seattle, who had chondrosarcoma that had spread to the lungs, was given nivolumab, one of those immune checkpoint inhibitors. And this shows two things. So the panel on the left, so picture A, is before treatment. And I don't have a pointer, but the sort of darker areas on the scan are the lungs. The white spots that are sort of really bright in the middle of each of those darker areas are tumors that are in the lungs. And the middle panel shows what happened after the patient was treated. It looked like the tumors actually grew. So the drug was stopped. But then later on, with no treatment in the middle, a scan a few months later actually showed that all those tumors went away. And that's a phenomenon that sometimes we'll see. It's not very common, but sometimes there's something called pseudoprogression, where if the drug is actually working really well, that can actually lead to immune cells going into the tumor, which on the scan can look like the cancer's gotten bigger, but in reality, those cells are going in there and they're actually fighting against the cancer. And then they keep working. And then down the road, sometimes that can actually be beneficial, and we can later on see that the cancer has gone away. But there are still many questions with these types of medicines. So first, how do we know which patients are going to benefit? There are some things that we're now learning with larger and larger numbers of patients with all different types of cancers getting treated with these drugs. So I think the biggest one is actually the number of mutations that any patient or individual patient has, where a higher number of mutations seems to correlate to some degree, at least, with benefit from these immune therapies. PD-L1 staining on your tumor is something you might have heard of. So that's how much of that protein that the drug actually targets can we see on the cancer cells. And if that number is very high, then that also suggests that maybe this would be a good option. But we know from studies that were done in relatively large numbers of patients with sarcomas that even though we see patients who benefit, it's a relatively small number of patients. And it might just be that we have to use a combination of the immune therapies along with other types of therapy, whether it's chemotherapy or radiation, to try and maximize the benefits and increase the chances that the immune drugs will work. And we're also still learning about toxicities. So on average, we think we have a good sense for what toxicities these drugs can cause, just because so many people have been treated with them now. But every cancer is different and every individual is different. And these drugs have only been around for a decade or so. So we're still even learning what's the long-term toxicity, what are the risks for some of the shorter-term toxicities. And then even if we know that these drugs might be beneficial for some patients, when should we actually use them? Should everyone who might benefit from it get it very early on, or should we wait to see if the cancer comes back? Because if we're able to cure already a significant number of people, especially who have localized disease, do we really want to actually potentially cause toxicity in patients if we're giving them a drug that they might not even necessarily need? There are other types of immunotherapies that are all being studied. Some have been more successful than others. Vaccines are one that have been studied for many types of cancers for a long time, and so far have not been particularly successful. But there is still great promise, and we're still learning more and more about how we can make the vaccines even more effective. Cell therapies are therapies where we actually take a patient's immune cells, modify them in the lab, and then put them back in to try and fight against the cancer. And that has actually been very successful in specific types of sarcomas. And there are certain types of cell therapies for other types of cancers, especially leukemia and lymphoma, that have been particularly effective. This is just a schematic of why those cell therapies can work. So this is a picture of, or I guess a graphic of a synovial sarcoma cell. So synovial sarcoma is one very specific type of sarcoma. And we actually know that they can express a protein called NY-ESO1. And that's not a protein that normal cells will generally have in them. And we can take advantage of that and try to actually make your immune system recognize that protein to then hopefully fight against the cancer. And that's actually being studied now in clinical trials. And it actually seems to be very promising. Some of the limitations with this, though, are that there are certain requirements that our bodies over time have, over millions and millions of years, have evolved to develop our immune system, where there's proteins called HLA proteins, which are proteins that are important for our immune system to be able to recognize various pathogens, so things like bacteria and viruses and things like that. And every individual, just because of our genetics, have different HLAs, and there are only certain ones where these treatments might work. And it's just a matter of genetics. You either have that one or you don't. Hopefully the drug companies will be able to more broadly develop these types of therapies. But right now it is very, very specific for certain types of HLA. And then you also have to have the protein that the cells are being engineered to target against in the cancer cells. The screening process can take a while. And then even if we know that patients are eligible, it can take a long time to actually manufacture the treatment for any individual patient, because we have to actually take the cells from the patient. They get shipped to a centralized lab where they're processed and engineered in a way that actually makes those cells recognize that particular protein. So in this case, NY-ESO1 for synovial sarcoma. And then once that engineering and processing is done, the cells then get shipped back to the treating center, wherever the patient is, and then can get infused. And that whole process usually takes about a month. Just to sort of say, well, what's actually happening on the horizon, and what are some new exciting things that sarcoma researchers are talking about? So just with the timing of where we are right now, the big annual oncology meeting is always the first week of June. And the presentations that are going to be presented at that meeting, so it's a meeting of the American Society of Clinical Oncology, or ASCO for short, those presentations were just announced last week. So I took a look through some of the presentations that are going to be given, and there are just a few that I thought were interesting and that I'll highlight. So there's one presentation of a drug that is specifically designed to target the fusion, so a change that we see specifically in Ewing sarcoma. That's a clinical trial that's been going on for a while. I honestly don't know what the result is. I'll find out in a few weeks when all of this data is made public. There's another trial that's going to be presented, which was actually an effort with SARC, the Sarcoma Focused Cooperative Group, where they looked at trametinib, which is a very targeted medicine that's blocking a particular protein in a very specific pathway for patients with a very rare type of blood vessel cancer called epithelioid hemangioendothelioma. at least some initial results of that cell therapy that I was just talking about are going to be presented, where that particular cell therapy product has been given to patients with synovial sarcoma and a specific type of liposarcoma, where at least initially we've seen some activity, and we're hoping in a much larger group of patients that that will be confirmed. There's some new combination of drugs. So temozolomide and olaparib are both drugs that are approved for other types of cancers. Temozolomide sometimes we'll actually use for sarcoma. Olaparib is a drug that is used for especially breast and ovarian cancer. So it's one that's used, I would say, most commonly in people who have BRCA mutations, but there's some evidence to suggest that it might actually work in leiomyosarcoma, especially uterine leiomyosarcoma. So this is a combination that, at least to my knowledge, has never been tested in patients before until this trial. So hopefully that will be an encouraging result. And then there's even new ways of targeting cancer cells. So pegylated arginine deaminase, or I don't know if I said that right, but that is a drug that targets metabolic pathways, which is not really generally a way that we try and attack cancer cells, but it's using data that a scientist who happens to be in St. Louis at WashU identified in the lab for looking at sarcomas specifically, trying to identify why are some of them resistant to gemcitabine. And this is what he identified, that this particular metabolic pathway seemed to be a factor that could be targeted with a drug and might actually make the cancer cells more susceptible to some of the standard chemotherapy that we have. And that's a new way of targeting cancer cells. Again, is this a clinical trial that's actually going to show benefit? I don't know. We'll find out in a couple of weeks, but we all hope that these studies will move the field forward and actually ultimately broaden the number of drugs that we can use. And then there was one talk which I thought was particularly interesting and important, where it's not a clinical trial per se, but it's a talk titled "Later Phase Studies in Rare Sarcoma Subtypes Are Possible," which is absolutely true. So rare sarcoma subtypes are called that for that very reason. They are rare. So there are some cancers, especially sarcomas, where there's only a few hundred people who get them every year. And because of that, historically, there just haven't been clinical trials that have been designed or done to truly learn how should we treat patients who have these very rare cancers. But now, with international collaboration and the help of cooperative groups, we're actually able to do large studies in patients, even with very rare cancers. So we're finally now getting good quality data that can help us make decisions. And we can, I guess, more comfortably make treatment recommendations, knowing that some of the things that we're recommending have been studied in larger clinical trials, rather than just personal experience with it, which is often sometimes what we have to make recommendations on. And now, just to finish out, I wanted to highlight some of the work that's being done here in Seattle. So this is just a selection of the science that we're doing, but we have a number of labs that are focused specifically on sarcoma and trying to learn what's the science that is behind these cancers, then how can we use that knowledge to then develop new drugs. And Dr. Chen, so Eleanor Chen, is a pathologist. So she is one of those people who actually looks at the biopsies that are done, looks at the surgical specimens, and helps to tell us as medical oncologists what type of sarcoma a patient has. But she also runs a lab, and she actually uses zebrafish, so little fish, as a model system to study specifically rhabdomyosarcoma. Laura Villalobos is in the Vaccine Institute at the University of Washington, and she's actually going to give the Northwest Sarcoma researcher talk coming up in the near future. But she's studying vaccines and how taking the knowledge of what we know now about liposarcoma and various genetic changes that are commonly seen in liposarcoma, and taking that information and then designing vaccines to specifically try and recognize proteins that are more likely to be found in an abnormal case in liposarcoma. And then we actually just got Dr. Beth Lawler from Michigan, and she is really just a phenomenal person and researcher. And she's based in Seattle Children's Hospital and studies Ewing sarcoma and has a big lab focused on that. And specifically, her lab looks at epigenetics. So that's sort of broadly trying to identify how different genes are activated and what proteins are present in cancer cells, and then also looking at tumor heterogeneity. So what we now know is that cancer cells don't come isolated. They are in a group of cells, basically, where there's support cells, there's immune cells, there's blood vessels, and all of those cells interact with each other to then allow a cancer to grow. And really, we have to look at that whole picture and all of the cells that are there. And the immunotherapy study or story that I just mentioned is really the prime example of why that's important, because those drugs, those immunotherapy drugs, are not actually targeting the cancer. They're targeting the immune system to then rev it up to then fight against the cancer. So the tumor heterogeneity and just the tumor microenvironment is becoming incredibly important now in our understanding of how cancers grow. And then I'm actually leading an effort which is involving a number of scientists across the University of Washington and Fred Hutch, looking at the immune microenvironment of angiosarcoma specifically, so rare cancer of blood vessels. And just in this picture, what that is that's actually an angiosarcoma from a patient, and we've stained it so we can highlight different immune cells. So the blue cells are all just different, or those blue dots are just different cells. The green is actually that protein that those immune therapy drugs are targeted against. And what we want to do is use that drug to basically get rid of those green cells, because what those green cells do is prevent the normal immune cells from going in and then fighting against the cancer. And then I also want to highlight patient-driven efforts at research. And I think the Count Me In program is really a phenomenal effort and initiative that was started primarily by Corey Painter, who's actually an angiosarcoma survivor. She also happens to be an excellent scientist based out of MIT at the Broad Institute. And from her own experience dealing with a very rare cancer, she started this initiative where patients with angiosarcoma sent in samples, and there's a consent process. And they've now spread that effort across a number of different cancer types. So not only sarcomas, but they have, and this is not a complete list, but I would encourage you to go to actually that website. And if you're interested in participating, I would highly recommend it. So they have efforts for metastatic breast cancer, I think gastric cancer, brain cancer. In the sarcoma area, they now have an active project specifically for osteosarcoma in collaboration with the Osteosarcoma Institute, which is another really fabulous patient-centered group specifically for folks with osteosarcoma. But what they've done by collecting these hundreds of cases and then analyzing them has been remarkable. And we're now seeing some of those efforts actually bear fruit. So what they did was they collected these samples, then sequenced them all, looked at the DNA changes that were in the angiosarcoma samples that came in from patients all over the country, in some cases even internationally. And they actually identified a subset of patients with angiosarcoma who have a high number of DNA changes, so a high mutation burden. And that then led and so first that suggested that those immune therapies would work, but then that led us to then develop a clinical trial, and we were able to add angiosarcoma as a cohort on a clinical trial specifically for patients with rare cancers. And that showed that there are some patients who actually benefit from this therapy. So I'm not going to get too much into the details, but what these graphs show is there were 16 patients who enrolled on this trial, and each of those vertical bars is a patient, and every bar that's going down is a patient whose tumor actually shrunk by getting those immunotherapies. And this is a clinical trial that was directly sprung from that angiosarcoma project data. So this is patients creating science that then led to a clinical trial that is showing benefit, and really, ultimately in the future, I think will change the way that we treat angiosarcoma for the better. So I guess just to provide some concluding thoughts, so research is a spectrum of science and clinical trials, and it really requires teamwork and collaborations. Without that, we can't really do anything. The immune system is increasingly becoming important for fighting cancer, and we're still learning how we can do it in the best way. But really, none of this research would be possible without the voluntary participation of patients in donating tissues, donating samples, and of course, participating in clinical trials. So thank you, everyone, for participating in research efforts, but then also for making it through this entire session with all these talks. So that was the last one. And now we can open it up to questions and hopefully get some of those answered. So. Okay, so sorry. So when I'm giving a talk, I can't actually see the chat. So I'm just gonna go back and look at some of these questions. And then also so Ritu has posted a link to just a feedback form. So we'd really appreciate your thoughts on really any of these talks, what the whole session, or how did it all go for you? And maybe while we're doing the question and answer session, feel free to fill that out. So just give me a second here to look back at the questions that have come up, and then you can also feel free to post them again. Let's see here. Let's see. So some of them are actually logistical questions. So I actually don't think there's one question. Are there any handouts? I don't think we have any handouts specifically, but all these presentations will be posted in just a couple weeks. Let's see here. There's one question. What are your thoughts on Rolfing? I have to say, I don't actually know what that is.
I do.
Okay.
I can speak to that.
Yeah, great.
So, Rolfing is a form of deep tissue massage, but it also involves energy change. I don't know it in great detail, but it's something that's very hard to study, and some people find benefit from it both emotionally as well as physically in terms of alignment issues. I'm not sure specifically what the participant was curious about with that, but it's been around for, actually I'm not sure when it started, but Ida Rolf was the person that started it. It looks like Joe maybe knows about it too a little bit, but it's not a form of massage that we would recommend because it lacks study for the kinds of things we work with.
I'm only familiar with it from my previous career as a dancer, and I know that a lot of dance,
Yeah.
a lot of dance studio or companies will use it as a form of PT and repair. So it is. I mean, it's intense for anybody that's really interested in it. I know that it's extremely intense, and it's really, really deep tissue. So yeah, that's my little bit of that I know about it.
All right, thank you. I just learned. I did not know what that was. I thought it was a typo and maybe golfing, but nope.
No.
Which, speaking of golfing, so the Northwest Sarcoma Foundation is having a golf event next weekend. So shameless plug for that. But to get back to some questions. So I saw one comment, actually, not even so much a question, that I want to repeat, because this is something that has been a challenge for providers, for patients over the past year, where the hospital visitor policy, because of COVID, has been extremely restrictive, where essentially patients were not allowed to have visitors. And that, we understand, is very challenging. And I think visitors in the hospital is very important for many reasons. It's not easy to go through cancer in any time, and this is an even more difficult time. So one little bit of good news is that, at least at University of Washington, just this week, they changed the hospital policy where they're now allowing at least one visitor. There were lots of arguments back and forth, and frankly, strong opinions about this that I'm not going to go into, because that gets into hospital politics. But really, all of, or most at least, of the oncologists feel the same way. We want visitors for advocacy and many other reasons, and we hear that, and hopefully now that the visitor policy has changed to some extent, and then also with vaccines becoming more widely available, we won't have to face that difficult situation again. But I absolutely hear that, and I hope that never has to come back again, where patients aren't allowed visitors. Let me see here. Okay. So there are a lot of questions. I'm trying to maybe group some. So why are some sarcomas slow growing versus others cancers? So that's a good question that sometimes we don't really have an answer to. So sometimes we just see the behavior of tumors, and different tumors will grow faster than others. There are certain types, for example, Ewing sarcoma or osteosarcoma, we know have an extremely high likelihood of spreading. So anyone with those cancers needs chemotherapy, versus others that just the general behavior of them doesn't. And a lot of that knowledge about the behavior of these cancers is just from seeing large numbers of people across many centers and over large periods of time, where especially even before various treatments were developed, when there were limited numbers of treatments, so say 100 years ago, people unfortunately would just see the natural progression of these various cancers. And that's how we've learned a lot, and what helps to guide our treatments. It's from what was seen many years ago, and then now we try and react to that. So are all clinical trial patients given the new drug or treatment, or are some unknowingly used as a control and get a placebo? So that really would depend on the clinical trial. There are some studies that are placebo controlled, where neither the patient nor the provider, so the oncologist, actually knows which drug a patient is getting. And really, anytime one is considering a clinical trial, you have to sign an informed consent. So all of that information should be made upfront clear. And that really does depend on the specifics of any individual clinical trial. Let's see, there were a couple of comments about the immunotherapies. So yes, there are some subtypes where it seems like immunotherapies are more active. So things like undifferentiated pleomorphic sarcoma or UPS, probably some subsets of patients with angiosarcomas are more likely to benefit from immunotherapies. There was a question about, so is undifferentiated pleomorphic the same as dedifferentiated liposarcoma? Those are actually different things. It's a lot of terminology, but dedifferentiated is a way that we specifically will describe some cancers of fat, so some liposarcomas, whereas the pathologists would call undifferentiated pleomorphic sarcoma a different thing. And it's really just, what does it look like under the microscope? And that's really where the pathologists are critical. Let's see, there was a question, so going back to my last comment about the placebo-controlled studies. So do the volunteers or do the participants find out which group they were in? And that also depends on the study. So usually there's a way at the end that we actually can find that out. Some studies will then allow someone on the placebo to then get what is thought to be the active drug. And that's actually the way most studies, I think, are designed. Because we do want, so even though for the science, we have to have that placebo-controlled arm, we want to maximize the number of people who can actually get access to those drugs. And by allowing for what we call crossover, meaning for people who get placebo to then get the active drug, if the placebo is not working, which would make sense, then a lot of studies will actually build in a way for all patients to eventually get the drug. Let's see here. So there were some questions about just repeating some of the, I guess, more technical terms. So I will defer those to when the slides and the presentations are posted, to some extent, because at least the one that was asked was a drug that I don't know how to say. So I can sound it out, but it was the pegylated metabolic one. Let's see here. So can you get clinical trial drugs even without being on a clinical trial? So that's a good question. It does come up relatively often. And the usual answer to that is it's much, or at least it's much more difficult. And usually the answer is no. So most of those drugs would only be available on a clinical trial. Sometimes drug companies will have compassionate use programs, and that's actually true, especially for the immunotherapies, because those drugs are now approved for so many different cancer types. The drug companies can provide the drug to people with rare cancers who wouldn't otherwise be able to get it. But especially for the new drugs, where we actually are trying to also learn if they're safe, those are drugs that the companies would generally not just be giving out, because the reason the clinical trial is being done is twofold. One is to see if there's activity, but then also we want to actually make sure it's safe. And particularly if that safety data is not known, then that makes it very difficult, if not impossible, for us to actually get access to the drug to be able to prescribe it. Let's see, so we're a little bit over time. So I did see a comment about having a 5-minute break, and I hear that. This was a long session. Thank you everyone for hanging in there. But again, I really appreciate all of your time, especially on a Saturday. Thank you to Kathleen and Joe.
Oh, thanks for having
and
me.
Ritu, and Dr. Lagers, who had to step away. But I hope you all got something out of this and it was a worthwhile use of your time. And feel free to reach out to us. This email is for the SCCA outreach. And if you have any other questions that you think of, you can send something to them and they will route it to whoever the right person is. So, you know, even though we're ending now, that doesn't mean we're truly ending now. And hopefully we'll have more events like this in the future. And thanks again.
Thank you. Bye.
All right.